It's already being recorded.
Yeah.
Achha. Meeting is being recorded. Okay. And, so, dear seniors, distinguished colleagues, and aspiring authors, a very good morning to all of you, and greetings from the Indian Association of Pediatric Surgeons and the Journal of Indian Association of Pediatric Surgeons. I'm indeed honored to be welcoming you all as aspiring authors to Scholarium, an innovative certificate course series which is brought to you jointly by the prestigious, dynamic, and forward-thinking Indian Association of Pediatric Surgeons and the respected, peer-reviewed, PubMed indexed, and internationally circulated our own Journal of Indian Association of Pediatric Surgeons. As a faculty in pediatric surgery for the past 12 years, as a medical writer with more than 180 publications and 16,000 cumulative citations, as your friend and colleague, I am delighted and humbled to present to you this series with our first module focusing on scientific paper writing. This initiative is basically a reflection of our commitment to enhancing the academic capabilities within our pediatric surgical community. See, we are all aware that scientific writing is not just about documenting our work, it's about contributing effectively to the global body of knowledge that advances our field and ultimately improves patient care. Through Scholarium, we have aimed to provide you all with practical insights and essential tools that will help you transform your valuable clinical experiences and research into impactful publications. So let us embark on this educational journey together and make the best out of it. I have the distinct pleasure of inviting our esteemed President of IAPS, Professor Sumitra Biswas sir, who brings dynamic energy, youthful vision, and boundless enthusiasm to our field. Sir, we would be honored if you could formally inaugurate this workshop and share your invaluable insights with us. Sir, please. Biswas sir.
कर लो एक बार जरा सा उन्हें कहीं कुछ
पहले रसिक सर से करा देते हैं, फिर विश्वास सर जब तक ज्वाइन कर लेंगे.
ठीक है.
So while Biswas sir is joining again, I am delighted to invite Dr. Rasik Shah, the distinguished editor of our own Journal of Indian Association of Pediatric Surgeons. Sir has been steering our journal to new heights of academic excellence. And we look forward to your valuable perspectives on scientific writing and publishing.
Thank
Sir,
you.
please.
Thank you, Prabhu. It is a pleasure to be part of this webinar where we are going to start our series to help authors to write the scientific publication. Being in pediatric surgery for now more than 35 years, one of the things which I lacked was writing well, particularly for scientific journal. So when I started private practice about 26 years back in Mumbai, I did not know a lot about writing, and this is something which no one teaches us, and we need to learn on our own. I am very happy today that there is someone who is going to teach each and every one of us who are interested in learning in scientific writing. It's not easy for all of us. There are some people who are good in writing and they will have publication like Prabhu. who already has 180 publication. I don't think at his age, whatever it is, to write 180 pages and 180 articles in scientific journal is, it is remarkable achievement. And I thank Vikesh, Prabhu, and the entire team to take this forward, uh, which we wanted to organize for more than a year, but finally it has taken off. And we should be doing this activity every second or third month so that all of us learn from this, everyone's experience. Now, as an editor-in-chief, my role is going to be being a catalyst between the authors and the journal to improve the quality of articles, to help everyone how to write, and a lot of things. As far as JIAPS is concerned, like all of you know that the number of submission and publication has been increasing over last few years. And we want now the quality. The quantity is definitely improved. Quality is also improving. We will like it to be further improved. Tomorrow or today, if anyone wants to, today what is happening is some of our articles are very good, but the world may not be taking notice of that. And we want people across the world to see JIAPS with respect. And that will happen when our work is reliable and put forward to the community, pediatric surgical community or medical fraternity well. And this exercise is going to definitely help us. So with these few words, I again thank everyone to be participating in this activity with more than 100 registration, which itself says that this was a need required, and today we are organizing this event. We have already 102 participants who are logged on, and next 5 hours, I think all of us will learn good amount of education in writing skills. Thank you once again for joining. Please take over. Prabhu, please.
Prabhu,
Yes, sir. Sorry, sir. I was speaking, but I didn't realize my mic was off. Thank you, sir, for your kind, encouraging, and intellectual words. I'm sure your words motivate our audience to a great extent. Sir, Sumitra Biswas sir ने join किया है
yeah,
क्या?
he has joined.
Yes, my mic was muted. I could not
Yes,
see
sir.
that.
Sir, we would be honored if you can formally inaugurate this workshop and share your valuable insights with us, sir.
Yes, after Roshi God has told you all the things which I wanted to speak, I welcome all the delegates to the Scholarium exercise and formally inaugurate the Scholarium. I think more and more will happen in the future. It is a very, 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 very good effort from the journal and the IAPS. Okay. Thank you all. Please start the proper session.
Prabhu.
Unmute, Prabhu.
Yes, sir. Thank you, sir, for your kind words. With your permission, we will start the academic sessions of Scholarium now. It gives me great pleasure to introduce our first speaker, Dr. Vikesh Agrawal, the Secretary General of IAPS. Under his dynamic leadership, IAPS has witnessed remarkable growth in its academic initiatives and professional activities. As Professor of Pediatric Surgery and Head of Department at Netaji Subhash Chandra Bose Medical College, Jabalpur, his commitment to academic excellence is well known. Sir has been the driving force behind numerous innovative programs, all academic and otherwise both, that have enriched our association activities. And today he will share his insights on Publish and Prosper, an introduction to the course. Over to you, sir.
Yeah, thank you, Prabodh, for your kind introduction. Can you stop sharing so that it allows me to share the screen?
Yes, sir. Sir, I stopped sharing my slides, sir.
Now, host has to allow me to share. I'm sending the request because I made Shivani host.
Shivani, can you please allow Dr. Vikesh to share?
Allowed, sir.
Okay,
Thank you.
thank you. So, a very good morning to everyone. I'm so honored to have all of you here, all the stalwarts in the field of academic pediatric surgery. So, it's going to be a brief talk, just introducing about the course, and I would like to raise certain questions in front of everyone, which may inspire or motivate you to write. So, three questions which always come in my mind: why to write, what to write, and how to write. So this Scholarium is all about answering these three questions. If you look at this systematic review we did for a period of almost 30 years in about the publications of pediatric urology from India, it is like very surprising, or like it is at times disheartening to see that India is doing so much work in pediatric urology and still we stand ninth in the world in terms of publications. So this thing is something alarming. And if we look at the quality of the publications, then almost 80% of these publications out of like this whatever data we did systematic search is very low quality, and case reports are almost like 645, while we have a very low 4.18% of high quality publications in terms of level of evidence. So we need to really improve upon it. But one good news is that most of the publications are written by pediatric surgeons, almost 60%, and that is something which shows a ray of hope as well as a promise. Another point which I want to highlight, like all of us do Wilms tumor, hundreds and thousands of patients must have been operated in India so far. But if you look at the data, this is like when we published 2 years back our series of 10 years of Wilms tumor. These are the only studies published from India, and out of that, only 2 of them are by pediatric surgeon. After our study, one more study has recently come up by Dr. Sareen, who has published 28 cases. So we are actually letting our data decay. We are doing so much of work, but we are not able to publish it. Even I published after 10 years, and that too during the COVID time. So that reflects a need of motivation. There is a recent upsurge in a lot of pediatric journals, but we are very lucky to have a journal like Indian Association of Pediatric Surgeons, which is meeting the quality, as well as it is PubMed indexed. It has international repute. So why not utilize our journal, put good articles, as our stalwarts Rasik sir and Sumit Biswas said. Coming to the next question, which always come in mind of common clinicians, especially those who are not working in institute or they are working in resource constrained setting, is what to write. क्या लिखें हम? हमको ये नहीं समझ में आता, ये तो छप चुका है, क्या लिखें? If you look at this article, it is the top 100 most disruptive papers in core pediatric surgery journals. And disruptive means something which made some change. And disruptive score is a score which evaluates the disruptive nature of the paper by using bibliometrics, including citation index and the impact factor. And if you see, these are the 3 most cited articles: gastrostomy without laparotomy, a percutaneous endoscopic technique, and just a simple study of 354 cases of intussusception in 10 years. And one more promising thing is of long-term results of fundoplication in hiatus hernia. So that shows that there need not be an experimental research for it to click. So there are so many things which has potential of developing disruption in the academic arena. On the basis of our experience, our team, we have a team of innovative surgery, the department of surgery in our institute. We have made a prismatic approach especially towards clinical research in resource-constrained settings, which include pragmatism, that is problem-solving approach. Then second is research. Research means we have to find the gaps, current gaps in the clinical practice in your particular area and publish accordingly. Innovate, find low-cost solution, modify techniques, develop techniques, and publish them. And then scrutinize whatever is the Western evidence, because Western evidence cannot be adopted completely by us. We need to provide Indian evidence to represent the global South. And the last, which is a little technical job, which we learn with experience, is measure. Measuring in academics is like more of statistics, validation, then a lot of like mathematical ways. So this is the higher level. So this prismatic approach is very useful to find out what we can publish. Coming to the next question, how to write. So now this Scholarium is the right platform which will teach us how to write a paper. So it starts with systematic search, and our dear colleagues out here, our seniors, experts, are going to talk about various nuances of systematic search as well as various features of the ideal manuscript. What is an ideal manuscript? So it should be like appealing to the reader. So if it is not appealing, it is something very traditional and which has been proven beyond doubt already, is not going to be accepted in any journal. It should be convincing, scientifically convincing manuscript. It should follow proper embroidered structure, which will be detailed further by the speakers. We have to focus on methodology. I always say that if discussion is heart of the manuscript, then methodology is the brain of the manuscript. So we have to work very hard and achieve a scientific rigor or a methodological rigor there in the methodology. Result should be complete and correct. It should not be presented in a wrong manner, conveying the wrong information, because ultimately you're contributing to international literature. And of course, discussion is the crux of the manuscript. And we have very good speakers, with lot of discussion and lot of efforts. We have handpicked the speakers who are experts in these particular subgroups of the manuscript writing. Coming to next important thing, we always think that we are not good at English. So it is not actually a creative writing class. But at the same time, we have to understand that journal space is precious. At times when we write manuscript, just to make it very attractive and flowery, we use a complicated language. We should use very simple language. We should be very concise, because poor science cannot be helped, but poor language can be helped. So both the things we have to remember. English is not a hindrance, as well as having a good English is not the strength to write a good manuscript. In short, if I say if clarity can be achieved in n words, we should never use n+1 word. So simple, short, precise, to the point manuscript is always appreciated and accepted. How to handle the basic statistics is one of the very big limitation of most of us. And I was a very enthusiast in statistics during my MS surgery days. So I always say learning basic statistics is very important, especially at young age, and you should keep on developing. Nowadays, it has become very simple because a lot of online mechanisms are available, and they're free also. You don't need to spend anything. In fact, ChatGPT nowadays calculate the statistics. We have very good speaker, and a lot of effort has been done by those speakers to create scenarios and solve those problems, show you how to do it. Coming to the one important part, that is reference management, which is supposed to be, this is a key area where most of the mistakes are formed. And it is one of the most annoying problem for the publisher, editor, and everyone. And one more area, like a lot of self-citation and these things which should be discouraged. We have also noticed that in JIPS articles, there is lack of, because I am reviewer also, And as editorial secretary, I have observed that we are not citing our own article. See, unless we cite our JIAPS article, how will we improve impact factor of JIAPS? So we should develop this habit of citing all Indian articles, one, and all JIAPS articles which are relevant to your particular research. So this is very important part. Nowadays, there are various programs available. I recently learned Mendeley 1.5 years back, motivated by my teacher, Dr. Ramesh Babu. And it is very useful. It makes your life very simple. Now we have to pass the first test, that is the editorial review. So we have to make our manuscript appealing to the editor, and it should have newness, it should have trueness, and it should be important. Because the editor, primary loyalty of the editor is towards science. And he's gatekeeper of the science. So he would allow those things to enter in the journal, which is important for the journal as well as important for the readers. Second test is the reviewer's acceptance. So second test, we have to learn what reviewer want. What is the common cause why articles are rejected by reviewer? Because it is out of scope. Sometimes they put non-pediatric surgery article in pediatric surgery journal. It is outdated. Hypothesis is not clear. And what result are there? They are untrue. They are not validated properly statistically. Discussion is not to the point and is not proving the hypothesis. And language is extremely poor. It's not about English. It's about how you put up the text, how the flow of the text is there. And we should understand that it is not a black hole. We should not be scared of reviewers' comments, critical comments, because there is always a choice to revise the paper. And that is the most important part where your paper gets the best shape. I have always experienced that before it is like very ugly, and after reviewers' evaluation, your manuscript really becomes smart. So Scholarium is intended to make smart researcher, and we all learn from Scholarium. Last but not the least, ChatGPT has recently emerged as a very important tool to expedite research, fasten research, and ease in the research. And I've been using it in tidbits. Many people think that people writing manuscript through ChatGPT is not a great idea. I agree with that. We are actually not writing the manuscript completely. We are using it in pieces, like generation of hypothesis, extraction of idea, doing some part of the systematic review or meta-analysis, summarizing our result, putting up in a better way, designing our study, calculating the sample size, doing the basic test, and whatnot. So all these things will be covered in detail in today's program. I'm very sure that it is going to be very fruitful to you. Last but not the least, we have to understand two ways of, evaluating your manuscript. That is, one is bibliometrics, which depends upon citation and impact factor, and recent upcoming concept of altmetrics, that is twitterism. So how your manuscript has reached to majority of the readers. Many a times people don't read journals. They promote their manuscript in the form of infographics or video abstract through Twitter, and that gathers broader attention. I would like to give one recently published example through one of the recently published article on altmetrics, which evaluated top ranked 101 articles in pediatric surgical journals. And you will be surprised to know the topmost article which achieved maximum attention and the altmetric score was highest was not cited nowhere. It has 0 citation. So both are equally important bibliometrics, as well as we have to promote our articles so that it reach larger audience in a very short, crisp manner. And if you see, the most cited article is standing at the 93rd position, which is on pediatric appendicitis score, which has almost 358 citations. So this is the importance of bibliometrics and altmetrics. So therefore, continuous learning is important. All of you are welcome to this course, and Hope you enjoy and give your valuable feedback at the end. Thank you very much.
Thank you, sir, for this wholesome introduction to this course. The next session is on clinically relevant research in surgical practice, seeking improved outcomes. The experts for this topic are Dr. Meenu Bajpai as the speaker and Dr. Sanjay Kulshrestha as the chairperson. I would like to request sir to take over now.
Thank you, Doctor. A very good morning to all. We must congratulate the organizing team of IAPS and GIPS for organizing this very special, unique, and much needed course like Scholarium academics for us. No matter how senior or junior we are, we all need such teaching for achieving a perfection in our paper writing. I would recall my professor, head of MS surgery. He used to sign the thesis or the dissertation only after seeing you have prepared a paper out of it. You prepare 4 copies and you put in an envelope and post it. Show me the registry receipt. Only then I will sign your this dissertation. So in that way, I got first publication. Without taking much time, I am inviting our first speaker, Professor Meenu Bajpai, sir. Professor Bajpai, as we all know, do not need any introduction. Besides brilliant academic experience of publication to his credit, and as part of editorial board of different national and international journal of pediatric surgery, is going to talk on clinical relevant research in surgical practice, seeking improved outcome. Many of us are working as an individual in smaller cities or in a smaller hospital, and not in the big cities or big institute or hospitals. So we may not be in a position to have a big research or that kind of work, but certainly we have enough clinical material during the course of our experience. So in that way, I'm thinking that this talk is going to help all of us. Over to Professor Bajpai.
Thank you, Dr. Kulshrestha. It is a pleasure to hear your beautiful voice once again after a long time. We had assembled here half an hour ago, and since then we have heard our colleagues of fraternity from Dr. Vishwas to Dr. Rasik, Vikesh, and Dr. Prabhuth. And obviously with your introduction of the situation, I think it is a wonderful effort by the General of IAPS and the current secretary and the president. They have taken big, huge effort under the guidance of our general editor-in-chief, Dr. Rasik Shah. So as everybody said, paper writing, once you're introduced to this, you get addicted. And the huge amount of paper, which at his age, Prabhuth has written is a testimony to if you are interested and you get used to it, you get addicted and the numbers come out. Good papers come out. So here I would, since there is it's a very structured program and time bound, and each and every aspect of the responses of reviewers, what the editor-in-chief expects, what should be the way to look for doing research would be taken up soon after my talk. I would rather introduce, taking the clue from my experience over the last 4 decades in pediatric surgery at Institute in New Delhi. I'll tell you how I thought about it. I will also stitch it with the current times of the new enhanced recovery after surgery practices, which unfortunately in developing countries are still not being practiced, although it is a concept which is more than 25 years old in the adult parlance. And the first international meeting was held in Canada on ERAS practices and on pediatric surgery. So I think at the end, I would like to encourage our fraternity, especially the journal and our association to took up. And this is the best time when we have Vikesh at the helm. So now I've requested Dr. Vinay from Jabalpur to present, share my slides. Vinay, are you up to it? The first slide, fair enough. So if I say change, please do that. So next slide, please. Yeah. So as I said, our specialty is a very unique specialty. What I'm going to talk about are first that clinically relevant research is when we identify the relevance when we practice and we come up about situations which are sometimes not so difficult and sometimes less difficult. But we try to seek answers for them. So if I look at what we define for clinically relevant research, we need to have improved patient safety, best practices for the procedures, reducing complication, and enhance recovering times by effective surgical techniques, introducing new technologies as they have come up, and the post-operative protocols, which are very important for good outcomes. Next, please. Now, enhanced recovery after surgery protocols, as I mentioned, has been already entrenched, and a lot of work is happening globally in pediatric surgery. Globally, there has not been much interest, but we should take the initiative and we should join the bandwagon of the few in the world who have actually started thinking about it. The aim of ERAS is to maintain physiological homeostasis, minimize surgical stress, facilitate recovery, and to reduce complications, length of stay, costs, and improve patient and staff satisfaction. So therefore, it is just not surgery alone, but is overall ecosystem which we have to handle. We are the leaders as surgery, but at the same time, we built a team around us, anesthetists, nurses. So this task force, which every institution should have, and the IAPS definitely would have it for the national level to initiate among institutions. The key principles is perioperative counseling, limited fasting for the child who is going to for surgery, introducing MIS wherever it is possible, seeing that child is early mobilized, reduce opioid sparing analgesia so that the sedation is unduly prolonged, and minimal use of drains and catheters, which again cuts down the morbidity. Next, please. Now, as I said, we have a unique specialty. We see kids before they are born as antenatal diagnosis, and then at the other end, we follow them almost lifelong. We see wide range age groups, from newborns to older children. We see various shades of the spectrum of the disease. Same condition comes to us in different shades. And unfortunately, sometimes the natural history is seen its most ugly form because they are not addressed, something which the West doesn't see. But we see it and we have to find solutions for them. And then we get opportunities because of this long follow-up to course correct what we have done, what we have been practicing, what we had learned 20 or 30 years ago. And we saw the result. We found that with the new technology, we can now give a new direction, improvised outcome to the same condition. This is a unique opportunity which pediatric surgeons get. Next, please. Now, I mentioned about the word course correction. Pediatric surgery, as I said, is very suitably because we follow up our cases and see the results. There are some examples which, if I find time, I will give during this talk itself. Otherwise, I'll leave it for some other situation. CACUT, the congenital anomalies and kidney of the urinary tract. These are conditions which have been increasingly understood, especially in the last decade and a half, by a lot of work done by basic scientists and then taken up as translational research by clinical scientists. And as a result of this, a lot of work has been published from our department also. There are situations that we see in hypospadias, disorders of or differences of sex development, which lead to penile deficiency states. We see a spectrum of conditions from crynosynostosis, aplasia cutis cerebri, etc. We have introduced MIS in a large number of conditions, and it has made the difference, robotics and laparoscopy. We seek to optimize results by modifying the techniques in such a way that we come out with better answers and better outcomes. And all this becomes a substrate for research publication. Clinical research is as important as the basic science research. As surgeons, we get hands on patients, as I mentioned about our unique specialty in a variety of conditions, so that we can deep look into it and find solutions to this and approaches which have reduced complications. Next, please. Vinay. So just to initiate and revise, a lot of youngsters would be there in the audience. We see a spectrum of conditions which are appalling. Look at bifid tongue. Next would be aglossia. So this extends, the pendulum swings from extremes. Next, please, we see full phallus. And then the next OPD, we may see a child without a phallus. Then next, please, we can see absence of skull, dura, exposed dural surfaces. And the other OPD, we can see prematurely ossified sutures, which is keratosis. See the spectrum. And therefore, I won't say fortunate enough, but we have the blessing in disguise to look at a lot of clinical material and see and deep think about it as to how we can bring it to the literature to share with the people in the world. So research involves asking questions, gather information, explore topics, and something mentioned, seek answers to various problems. And it's a systemic investigation that can lead to new knowledge or insights. Next, please. So I'll take a few examples just to take you along as to what I have done and our department, my colleague, especially Dr. Prabodh had been most long associated with me, and we have seen it with very close quarters. So congenital anomalies of the kidneys and urinary tract, major ones are pelvic junction obstruction, posterior cell valve, vesicular reflux. These are enigmatic conditions because for the last 3 decades, people have been trying to improvise their outcomes, especially after the antenatal diagnosis. We became clueless as to when and how to treat, especially in PUJO obstruction. Next, please. So let me take the example. 35 years ago, in 1986, there was a first editorial by Stephen Koff, where he said, when we make an antenatal diagnosis, we see a hydronephrosis, and we sometimes don't know whether it will be self-corrected or it will need surgical intervention. As a result of that, we realized that earlier children were presenting with symptoms like pain, lump, urinary tract infection. But once the antenatal diagnosis was made, next please, we soon realized that we have got a asymptomatic kid, a family which is unsuspecting, and then we tell them that you have a baby with a problem. Now, this raises huge anxieties, and we are there to address it. Next, please. So when these babies were born and they were antenatally diagnosed, we put them to the same test. For example, in short, doing a renogram. When you do a renogram in a young child, we sometimes see equivocal curves instead of complete drainage, which is normal, to obstructed, which is straight away surgical indication. We see equivocal ones, which during follow-up may take any course. It will become normal, it will get obstructed. Now, sometimes this delay is very prolonged. And in this process of waiting, we make a retrospective diagnosis. If the kidney function falls, we believe that probably it was obstructed, now we would operate, which means a retrospective diagnosis, and we may have lost some function. This is not state-of-the-art medicine. Therefore, it falls upon us that we should look at these conditions and try to upfront answer. This is a case which is born, has a surgical case, and we should operate. And this is a baby who would not be a surgical case instead of procrastinating follow-up. Next, please. Now, so these questions we ask, we have to ask this question, as Dr. Vikesh mentioned, what do we write? How do we think about it? This waiting risks renal injury. So we ask these questions. Is there a discriminatory factor which can tell us upfront we are dealing with a surgical case? And why function does not always recover after surgery? These questions you have to ask. And when we see patients, these are natural questions. Next, please. So we looked at if the function is falling, what is the mechanism which leads to falling of function? So there is a fall due to angiotensin II, which leads to profibrotic activity, apoptosis, and in the process, lot of urinary cytokines are thrown. These could be identified. Next, please. So if you look at this pathway next, these are the footprints. If you look at angiotensin II on the top left, which has led to injury in the tubulointerstitial compartment, this injury cries by throwing it a lot of growth factors, TGF beta 1, etc. And they can be detected in urine. That means that these are footprints of something like a damage is happening. Next, please. So where does it come from? Now, this particular pathway is activated due to the presence of juxtaglomerular apparatus, which perceives some hemodynamic homeostatic changes, and that leads to a boomeranging or a spiraling effect of leaving behind certain factors which would lead to a cascading effect on the renal function. So let us see the next slide. And here you see that the entire pathway of renin-angiotensin system, for which the apoptosis causing is that lower down in angiotensin 2, but it's the first player in this whole field is the plasma renin activity, which is shown by that glittering arrow. So this particular thing triggers a cascade of effects. Next, please. Now here, so when we did a post hoc analysis, we followed up our cases, just like I said, it was retrospective diagnosis. And when we started looking at our data, we found that those kids who underwent surgery had long period of time raised plasma renin activity. So there were disturbances in the homeostatic mechanisms already, but they were not picked up by our regular tools of DTPA scan or an ultrasound. But if we go more molecular, and now nanotechnology is coming up as well, we can make an early diagnosis, we can operate, and you can see that as soon as we operated, there was a fall in renin activity, which means the damaging factors were taken away. So this was the thought process which started in a situation which was given to us, antenatal diagnosis, when to operate, is there a discriminatory factor? And we realized, yes, there is. Next, please. Non-operated cases continued, and we published it in Journal of Urology almost 20 years ago. Next, please. Now, this such a publication then spirals a spate of activity. These are pilot studies which enthuse interest into researchers across the globe, and then the cumulative data start appearing, which form the basis for meta-analysis and systematic reviews. Further, we added, and we need, and very soon down the lectures coming down, we will come across how we do analysis. And the Kaplan-Meier survival estimation on the basis of available tests, split renal function, glomerular filtration rate, titrated against PRA, showed that PRA was the best marker to make an early diagnosis, which led to early intervention as well. Next, please. This is just a thought process which I've shared when we see cases which are so common and they are intriguing. The whole globe is thinking about how to manage them, and they go in for procrastinated and a retrospective diagnosis. Here are we with large number of cases which you can do into research, accumulate data, and systematically put it into a paper. Now, second CACOT is posterior valve, which contributes to the maximum number of CKDs. At this point, let me request Dr. Vinay, just tell me 5 minutes before my time ends so that I can curtail what I'm saying. So in
sir, you have just 3 minutes is remaining, sir.
Okay. So in posterior valve, we applied the same philosophy as to following up these cases. We found that the posterior valve contributes to a very high morbidity. So we looked at renin, we found, yes, indeed, renin is high in this group also. It cuts down, and if the damage is continuing, renin is high. Next, please. So I'll quickly go to the beyond CACOT now. So keep moving the slide. We applied these changes and we found, next please, keep not changing because time is not there. And now that I have laid down the background, everybody will follow. We looked at renin, which is an indicator of early injury. Would gradually shows a variety of processes, and this pathway can be blocked, which this blocking photograph is showing, and which results in improvement in function also. So it is not that we can make an early diagnosis alone. Please keep moving the slide. Vinay, thank you. So that keep moving, because I'll now keep speaking running. I won't ask you for change. Now, therefore, the same thing was applied for modern management of vesicular-ureteric reflux. And we realized that people say, especially pediatricians and nephrologists, that VUR is a medical condition, and we established in many papers that it is a condition. If you keep on treating, you can have intention to treat VUR. We intend to cure reflux forever. And if we don't cure, these mechanisms continue to work. And we have many a times established that the damage is there to be seen if you don't act early. We also looked at genetic aspects of the disease. And we found it our Indian children have a propensity to genetic polymorphism. For a same child who doesn't have polymorphism has a good outcome. Those with polymorphism would have a poor outcome. Therefore, this pathway, just stop for a second here. So this pathway, RAS, can be blocked in order to recover function. And that was something that was eye-opener to us. Now, coming to surgical condition, we get challenging conditions like aphalia. In this case, I am showing that we were able to raise a flap from the scrotum itself by virtue of our knowledge of good supply of the scrotum. And next, please, you can now start moving again. If in some of the surgical condition, we were able to create this phallus, which to tide over early childhood. And later on, we did many reconstruction. Similarly, next, please, in differences in sex development, after urethroplasty, the penis doesn't grow. It's a very frustrating condition. Young kids, adolescents, they go to colleges, but they run back from there due to a phenomena called locker room syndrome. And the family is devastated. Sometimes they have suicidal tendencies. To create long phalluses, there have been many, many procedures which are very disfiguring. And they don't sustain the test of time because there is fibrosis, atrophy of muscles, resorption of fibula, which is given to phallic sizes. Here, we thought that we can do something which our pediatric surgeons, with the good training that they have, they can do, because it's a common condition. We don't find microvascular anastomosis, plastic surgeons, etc., who would be available for such plethora of conditions that we see. So we created a procedure so that most of our pediatric surgeons can do. Next, please. And this is called bird wing phalloplasty, which next, keep moving, please, Vinay. You can quickly move to show these flaps are created. We can create a scaffold for it, and in this we can put in implants. So large phalluses could be created, and this is done after adolescence, so there is enough fat. Similarly, we'll just stop for a second. In esophageal atresia, sometimes strictures where we have to do esophagoplasty. We did isoperistaltic gastric tube, because one challenge which we hear also from our ENT surgeon, pharyngeal strictures cannot be bridged by the conventional procedure. But if you see the diagram here, you can see that you can create a tube going even to the lesser curvature. And so therefore, the long gaps could be bridged by a modified procedure, which is again a clinical research. Next, please. And we then, next, please. Last few slides. You can create very long tubes, which are isoperistaltic, which can then be taken up right up to the neck. We published it in the technique. We found very good questions from the reviewers, and we were very happy that we did it. Similarly, we introduced laparoscopy. In fact, very few people in the world were doing it at that time. And especially in our country, we see very large tumors. And therefore, it is very difficult to do laparoscopic handling. It is just unfortunate that the morcellators, which are supposed to suck out the tumor, have been disfavored by FDA because of seeding. Otherwise, doing laparoscopic removal of the tumor can reduce huge morbidity in sick children, which are pediatric. Most of the malignancy cases are. Now, as we conclude towards this part, I would say that we should never get disheartened if our work done a few years ago had been questioned subsequently, because science is not the truth. It is the search for truth. You would be appalled to know that even Einstein's work was challenged 5 times, and one time it was challenged by an Indian, Dr. J.C. Bose. I'm sure all of you know about the Einstein-Bose law of condensation. So we, as a specialist, look at things, we come across situations, whichever they are, there's always food for thought. There is always something that we can show to the world, and especially to our journal. Next, please. Very fortunate to have our journal. And iske pehle jana hai to message to Journal of IPS. Can you go to So basically, we should create a task force unless there is one already. And this would have surgeons, anesthetists, nurse coordinator, research personnel, and ancillary medical personnel, dietitian, etc. It should not be a one-man show alone. It should be a teamwork. And through this ERAS implementation roadmap, we can improvise a lot of conditions. Especially, we can actually initiate a lot of our youngsters to start thinking differently, and so that the karma continues. Next, please. Now we can move, finally saying thank you. And I would like to say, as the Vice President and the former Director of the National Board of Examination, we have introduced as the governing body a 2-year fellowship in artificial intelligence and machine learning. We have already in a very advanced stages with the IIT Madras and some other IITs. This has gone through our governing body also. We are just going to introduce AIML for pediatric surgery, would be a great boon. And a task force on ERAS and this current sort of board of executives in the Journal of IAPS and IEPS probably is going to show the way to our next generation. Thank you, everyone.
Thank you, Professor Vajpayee, for sharing your vast experience. Since we are running a little short of time, I would like to give over to for the next proceedings. Over to Dr. Vinay, please.
Thank you, sir, for providing us insights into this topic. Moving forward to the next session now. The topic is study design and methodology. The speaker is Dr. Prabodh Goyal and the chairperson is Dr. Prema Menon. Kindly take over, sir.
Okay. Thank you very much for making me part of this program. I think that whenever you want to publish a paper, it's extremely important that the study design you have to spend a lot of time. It's like, you want to make a building or something, your initial plan, the architect has to make a good plan for you. Otherwise, everything else is lost. You finish writing a paper, it may not get published, or it will not get a proper, recognition. So our speaker is Prabodh, and as everyone has mentioned, at a very young age, he has a lot of papers, a lot of experience of writing papers. So I think this is one of the most important. I think more than even discussion, study design, methodology, and collection of data. These are most important. So over to Prabodh.
Thank you, Professor Menon. Thank you, everybody, for being here. I'm glad we have 137 participants now. Am I audible? Somebody please confirm.
Yes, you can hear very well, Prabodh.
Yes, thank you. So I'll be talking on study design and methodology, I believe, which forms the basis of writing any manuscript. So if we look at the classical structure, these are the headings that figure out in any manuscript, particularly the original article. When you look into the information for authors, particularly for JIAPS, in general for all journals, they say the text should be divided into sections of introduction, methods, results, and discussion. Key message should be provided at the end of the manuscript. So essentially, of all these, material and methods is generally the most important, and this is the first section that you write when you are planning to write a manuscript. Now, this happened. I had a lecture recently in the annual conference of research section of IAPS. I was presenting on a related topic and I was trying to make an analogy, and I realized that the entire manuscript, the various steps in the manuscript can be compared to the dating story, where probably the cover letter you write to the editor is the first move. The title and the abstract, they're like the mini skirt. So long enough to cover the essentials, but small enough to maintain interest. The introduction of the manuscript is the first date. Methods is the perfect plan. This is what we'll talk about in this paper. The results is the success story, and discussion is the reflection. So essentially, the method section is like planning the perfect romantic evening, so much so that every detail must be carefully orchestrated. The sequence does matter. Nothing should be left to chance, yet it should be described with elegance rather than awkward explicitness. So a well-written material method section is a detailed roadmap of how the study was conducted. It will allow the readers, the reviewers, the editor to evaluate the validity of your study. And it is an opportunity to address potential concerns preemptively. Finally, it's a blueprint if somebody else wants to replicate the same study. So in this presentation, I'm aiming to cover the essential components of writing a robust methodology. We'll talk about the theoretical foundations and we'll discuss the practical implementation strategies. Now, I read somewhere that the method section should flow naturally from your research question and objectives, creating a logical bridge between what you aim to study and how you plan to study it. So these are the various steps which are essential. We'll come on them one by one. So you need to understand three important things in research design. One is selection of research approach. Other is selection of study design, and third is sampling and participants. Let's talk of selection of research approach first. So we are all aware it can have a qualitative approach or you can have a quantitative approach. These terms are self-explanatory, but to talk a bit, quantitative research means you can do hypothesis testing. For example, if tissue glue reduces the rate of UCA formation. So see, there is the rate here that is quantitative. You can find the relationship between variables. For example, impact of screen time on sleep quality, where sleep quality is given some numbers. So now the essential objective or target of quantitative research is to be able to generalize your findings to the population. For example, analyzing results of tips in the hands of multiple surgeons, and a good amount of statistics is involved in it. I'll just give an example here. So this is a research question, one created by me. Does a new mobile health app improve compliance to oxybutynin? So how do you write down the methods? So a quantitative approach using randomized control trial was implemented to evaluate the effectiveness of mobile health application. The method was selected to establish causal relationship between the app usage and adherence to oxybutynin. So you mentioned it's a quantitative approach. You mentioned the study design, randomized control trial. You justified the design here. Then you say data collection involved tracking medication compliance through electronic monitoring in a sample size of 500 over a time period of 6 months, enabling statistical analysis. So this is classical description of a quantitative method. On the other hand, qualitative method talks about complex phenomena. For example, examining the burnout of the postgraduates in medical colleges. So these are individual experiences, personal experiences, which are not to be quantified into numbers. So two more examples, like creating theory about motivation of residents towards empathetic care, or analyzing the workplace dynamics between doctors and nurses. So if you just introspect for a second, you'll realize that these three examples, you cannot do a quantitative research. It has to start with qualitative research. An example again. So this is about long-term cancer recovery. How do patients experience long-term cancer recovery? So now a qualitative phenomenological approach was adopted to deeply understand the lived experiences of cancer survivors. So see, qualitative, phenomenological approach and lived experiences. Semi-structured interviews were conducted with 15 participants who completed treatment over 5 years. So this is classically the methodological write-up of a qualitative study. So just a table, I'll put it on the this group chat to help you understand the differences between qualitative approach and quantitative approach. So quantitative approach, you can do hypothesis testing and establish relationship between variables. Just to revise, qualitative approach, complex phenomena, subjective experiences which cannot be quantified. Now, when you need both a bit of qualitative and a bit of quantitative, it is called as mixed methods research. So here you have two dimensions. One is qualitative or quantitative, what they call as breadth and depth, generally required for complex research questions. So the quantitative phase will involve surveys to identify the common concerns, and the qualitative phase, semi-structured interviews. So basically, this is an example of a mixed method research. You are trying to understand how the spouses of patients who had hypospadias feel. You don't have baseline data. So initially conducted surveys to identify the common concerns. So you made a list of concerns, and then you quantitatively studied those concerns in a larger group. So the first part is qualitative, other is quantitative. And you should write a justification in your method section. This method, whatever your method is, enabled the specific advantage while ensuring you talk about reliability, generalizability, or validity. This line makes your methodology very robust. Now, second aspect is selection of study design. So broadly speaking, we can have an experimental design, We can have a quasi-experimental design, or we can have an observational design. Now, what is an experimental study design? So as the name suggests, there has to be some experiment, and patients are randomly assigned to two conditions, and we are doing pre and post measurements. Classically, we do randomized control trial, which is experimental study design, but it can also be a factorial study design and a crossover design. So in an experimental design, it is like, okay, you have a control group, you have a study group, the participants are randomized between the control group and the study group. We all know what's an RCT. I'll talk about the factorial design. In factorial design, you have more than two groups. For example, we are testing two drugs, A and B, and we are testing each drug at two levels, say low dose and high dose. So read the last line. So we can have four groups, low dose of A and low dose of B. Second group, low dose of A and high dose of B. Third group, high dose of A and low dose of B. And fourth group, high A and high B. So this is classically a factorial study design, generally good for the medical studies. Finally, it's a crossover design. In crossover design, each limb will receive both the treatments with a gap in between, which is called as the washout period. We go to the last line again. A trial where participants receive drug A in the first period, then there is a washout phase to allow the effects of drug to wane off, and then they receive drug B in the second period. This is called as a crossover design. Together, these three comprise the experimental study design. Now, in quasi-experimental, which is very common in surgical side, the patients are not assigned into treatment and control groups randomly. For example, you're trying to compare TIPS and TDU. So we all know that all the patients who undergo TIPS are not candidates for TDU. So if a surgeon decides to do a study, but he does not divide the patients randomly into two groups, it is a quasi-experimental design. So non-random assignment, pre-post comparison is there like RCT, control group alternatives, and it works in the real world settings. RCT is more of an ideal setting. Third design was the observational studies. We are aware of all these three terms: case control studies, cohort studies, and cross-sectional studies. Now, what are case control studies? It is a retrospective observational study. So we are trying to figure out the fistula formation in hypospadias and the factors associated. So we take a group of patients who had hypospadias and landed up with a UCF formation. They will be your cases. Controls will be those who did not land up with a fistula formation. And we study these two groups retrospectively to identify what were those factors which were different between the fistula group and the non-fistula group. On the other hand is a cohort study which goes prospectively, but then we have prospective cohort studies and retrospective. A lot of studies that you publish in medical side are retrospective cohort studies. I'll give an example. I am doing MCH and my guide says, okay, better you pick up all the cases of Wilms tumor and do an observational study on them. So such studies are retrospective cohorts. Why retrospective? Because these patients have already been managed. I'm taking the data from the files. Why cohort? Because I'm going back and starting this patient presented with a lump in abdomen with a history of 5 months. From there, I start, we investigated like this, we administered this treatment, this was the complication, this was the outcome. So the second most common design that we encounter in our surgical studies is a retrospective cohort study. Finally, a cross-sectional study. Like a cross-section, you take the observation at a certain point of time. So you are trying to make a nomogram of stretched penile length in children. So whosoever comes to your OPD, you take down the age, height, weight, and stretched penile length. This is a classical cross-sectional study. So we understand that an experimental study will establish the strongest causality as compared to the other two designs. An observational study can only be correlational. This is the selection matrix for these studies. Now, third is sampling and participants. So we know we have a target population. We select a sampling approach and we derive a sample for our study. So like from one of my studies, we decide the target population is boys aged 1 to 14 years. presenting to our clinic for unrelated conditions. Then we had to choose a sampling method. It could be a simple random sampling when every participant has an equal chance of being included. Stratified sampling, we say we'll select in groups of 2, groups of 3, and so on. और convenience sampling, what we are most commonly doing कि जो patient आ जाएगा, जो patient available होगा उसको ले लेंगे. Purposive sampling, where a very specific group. We will include patients who have bilateral Wilms tumor with lung metastasis. So this is purposive sampling. So we have seen here, we included consecutive volunteers. This is my sampling description in this study. How do you determine the sample size? So these are 4 factors: power analysis, effect size estimation, confidence level, and expected iteration. You should understand the basics of sample size determination, but you should definitely involve a statistician when you are doing a determination. Then you define the inclusion and exclusion criteria for your study. So whatever you have included, some of them may be excluded for certain reasons. So we said that, second line, those with genital or other disorders which could affect the length of the penis were excluded because we are trying to make a nomogram. Then you need to mention about the patient demographics. So read the last line. The final sample, 145 was the sample size, included participants aged this to this. Response rate was 78%, and attrition analysis revealed no significant differences. Data collection methods. So you have to describe the instruments used, like the measurement tools, validation of the tool. You have to describe the data collection process. 6 months was the time used. We did online surveys and we had taken an ethics approval. You need to talk about the tests used for quantitative analysis and the tests used for qualitative analysis. You have to mention about the writing strategies. So this is how the most important line is at the bottom. You have to strike a balance between detail and clarity. Like Professor Vikesh said, words do use evidence, stay focused, and be systematic. So there's 4 basic groups which each your method section should outline. And like planning the perfect date, every detail matters. Timing is crucial. Now, some special consideration. One is ethics, which is mandatory. Your section should be so described that another author should be able to replicate your study. Now, this is one approach which I recommend to my new students, template-based strategy. If you have conducted a study, identify a similar paper from literature and use it as a template to construct your own manuscript. This can be used by the new authors. Reverse writing technique. I always recommend to my resident that start with the method section, then write the results, then go to the discussion, introduction, and conclusions in the last. Then you need to identify a target journal. Remember the scope of your research and the again, like Professor Vikesh has talked in detail, we have a lot of tools available in literature for writing your manuscript, for statistical softwares, for the AI tools. Use them. Important to plagiarism, but make the best utilization of these services. Thank you very much.
Thank you very much, Prabhu, for finishing on time. I just one question which comes to mind when a person wants to set up a paper or a research is how many study patients should you have and how do you calculate it? I'm not very sure if we discussed that. And second thing is the controls. From where do you select them and how many should you have based on the number of study patients? Basically the core group. How many controls should you have? These 2, could you answer?
Yes. Yes, ma'am. That's a very wonderful question. So I think that is the crux of the study as to what should be your sample size and what should be your control size. I just share my slides again. So like we discussed, so there are 4 factors which determine sample size estimation. One is the power that you intend in your study, the effect size that you are expecting, the confidence level, and expected attrition. And generally we represent it like this. I am reading it out because that will help the youngsters understand how to calculate the sample size. So in a study evaluating the success rate of a new surgical technique for hypospadias repair, power analysis might determine that a sample of 100 patients, so this is what they have calculated, a sample of 100 patients is needed to detect a 10% improvement in success rate. So somebody had a suppose the baseline reported fistula rate in after hypospadias repair is 30%, and you're describing a new technique. You say, I will consider this technique better if the rate comes down from 30% to 20%. So that is 10% improvement in success rate, assuming a medium effect size, and ensuring 80% power with a significant level of 0.05. A confidence level of 95% is usually chosen to provide precision around the estimates. Then you have to add the attrition rate, because not all that you operate will come for follow-up, arbitrarily 10%, and an additional 10 participants are recruited, bringing the total sample size to 110. So see, these are the 4 points which are important. As residents of surgery, you should be understanding that these are the 4, you should be able to recall these 4 points. You will be required time and again. You should be able to understand what is the basic information you should have when you are going for sample size determination. But I would still suggest that when you actually do it, keep a statistician by your side, because if you go wrong in sample size determination or determination of control size, so then the entire study goes waste. Now for controls, the ideal situation is 1:1, one case and one control. But you want to make a stronger study, you can have 1:2, 1:3, 1:4, where controls outnumber the cases. Alternatively, there are restrictions because maybe the controls are not available, or maybe, say, for example, we do whole exome sequencing. A single test costs around 25,000. You may not want to invest an equal amount in the control. So that is a little bit of dynamic depending upon study to study. But then this slide has the essence of it all.
Yeah, correct.
I hope, ma'am, that answers the question.
So the study patients, I think it's the time you have to do the study that is also important. And wherever you are working and what kind of patients you get, that will also help you in putting up a good research work. There are no other questions. Then thank you very much, Prabodh, for an excellent talk. So I think we can move on to the next talk. Thank you.
Thank you, ma'am.
Thank you, sir, for such an interesting session. The next topic is literature review. The experts for this topic are Dr. Kiran M. as the speaker and Dr. Shubhashish Saha as the chairperson. I would like to request that they take over now.
Yeah, thank you. So once we have, Dr. Prabodh has very nicely demonstrated how do we select and describe the methodology. And once that is in place, the next priority is the literature review. So basically, we want to know what is the existing knowledge regarding that topic, how we justify our research questions, and what's the overview of the current state of the literature, and where are the gaps where we need to put in our efforts. So I would like to invite Dr. Kiran M. He has been the adjunct faculty, NMC Nodal Center, and at St. John's Medical College, and he's also the honorary secretary of Karnataka State Chapter. So over to Dr. Kiran, please.
Hello, good morning, everyone. Am I audible?
Yeah, perfect.
So thank you very much, Dr. Shubhashish Saha. At the outset, I would thank the president of IAPS, and a special thanks to our secretary, Dr. Vikesh Agarwal, who has been very helpful in doing such a programs, which has been useful for us as well as the junior faculty and the students at this thing, because as we all know, it is very important from the NMC point of view for our for promotions as well as the rating scales which you have in our institute. So without wasting much time, this PPT have been prepared to keeping the residents. So I've kept it very simple. I have not added too much of material in that. So what we all know, literature, a review of a literature refers to any collection of materials on a topic, and it doesn't mean that necessarily it's a great literary text. Okay, so the literature review is a survey on a specific topic. Okay, like if you take a example of a posterior urethral valve. Okay, it provides of what? It provides about the current knowledge about the posterior urethral valves, and it allows to identify this relevant theories or whatever research has been done, what are the authors who have been published them. Okay, and what is the main important is the gaps in the existing research. So with all this, what we can do is a review of literature. It applies to the students who are doing their research paper, theses, or even their dissertation topics too. So what isn't a literature review? If it is an annotated bibliography wherein the writer he presents a summary or a critical evaluation of the article or some resource of scholarly importance one by one, and it doesn't have a connection between the other articles or the resources, and it's just an bibliography and a summary, it's not literature review. So what I did, as usual, I went to my Google Guru and asked Google, so what exactly is a literature review? Because literature review is a vast topic by itself to start. So this is the platform which we thought. So these are all the various purposes and what types it does a literature review include, and what are the things which we should consider when we do, and what are the other articles. So this was what I found out by Google. So literature reviews, basically, as I told you all, it also gave me the same summary. It is a recap of important information of the source, but a synthesis, reorganization, or reshuffling of that information. It will trace the intellectual progress of the field, which includes even major debates about whether for or against that. And it has always been a part of a scientific research. Okay. Evaluation of the literature review, it logically leads to what research question we have. So as Sir has previously informed us that when you have a research question in mind, how to go about that. So how do you fix your research topic regarding the literature reviews? So what we do, we search for related published literature. So, and in that published literature, I'll come in the searcher that how when we go to searching the literature, how do you skim out literatures which are more relevant? And what are the codes for these literatures? How do you create a conceptual schema? And then how do you start writing your literature review? So literature search. So what we did was, so we perform a preliminary search of the literature, then see what other works are there in the literature which has already been published. So what does that do? It gives a preview of the number of articles which is available in the topic. Like, for example, as I told you, if you search for post-urethral valve and fulguration, you get around 675 articles. So we are not going to write the literature using all the 675. Then what it does is, then we go to the recent journals. Like maybe we can look at whether you're looking at a 10-year or a 5 years, or in the past year, what has been done. And then we modified that. Okay, so the recent journals is the central topic which we look at the research, the literature review, and it provides the content, what should be in the review. For example, we list a subject headings that relate to the themes of those interests when we do that. So when I looked at what I meant about that, to consult the Web of Sciences Journals Citation Index, because this gives an idea for the most important journals in the field. As I told you, if there are 675 articles, and then we go there and we skim it out. So we get like this. This is what is Clarivate. So here we can go and in this search, we can add post-urethral valves, and then we'll know whether it is important, and the topics of importance and good journals which are indexed will be available to us. So this is one of the ways we can do. So what we do, we search across multiple databases and information resources. May not be only PubMed. We have many. We have Google Scholar, we have Scopus, and right now we have chatbots which will do work for us. We have a lot of AIs which will go and search, like Skyscape is there. Okay, Rabbit is there. So there they go and you give your area of interest, like a posterior valve in children, plus or minus fulguration. So they go and skim out all the articles for you, and then they'll enter. So this is, and at the same time, what we need to do is, whenever you're looking at, you should not look at only the headings. We need to go through the literature each time after we have made down that what amount of topic you're going to bring about. So you read your, it will guide you for the subsequent searches and refine your topic of your interest. Like when I told you, like if you have taught about in systemic research about going into a topic. So then it will refine your topic. So another thing important is when we are done, we should know when we have to stop this searching. Okay. So what it means to say is when you find the same authors wherein they're writing about the same thing, recurring authors, and then if it is the same recurrent institutions or the labs which are providing the same reports, or recurring settings of experiments, or if it is there, or recurring methods or results, okay, and you know that these are the patterns, they will be there if you want to do your research. And sometimes if the materials are too old or you have you're out of time, then afterwards what we need to do, we need to create a conceptual schema. So how do we do that? A topical order. It's organized by main topics or issues, and it emphasizes that the relationship of the issues to the main problem. And then we come to the chronological order. So by the dates, when was it first started? Who was the first person who told us about this topics? Okay, and then we go on to the chronological, wherein we organize that, and then we come to the problem, cause, or solution order, so that you organize the review so that it was moves from the problem to the solution. Then we go. So basically, the types of literature review in an organization are, it can be chronological, thematic, and methodical. If it is a chronological, it is useful if the sequential orders are very important. And if it is thematic, we use this to go from general topic schemes to be more specific. Okay, like from education to higher education to writing centers. So that's the examples we go like across. And in methodological, use this type if the methods of the researchers, the writers are most important. So this is what I told, that in general to specific order, it is a funnel approach, and specific to general order is to make the discuss specific research studies to the conclusions can be drawn. So how do you conclude? After reviewing the literature, you should summarize what has been done, what has not been done, and what needs to be done. Okay, so remember that you're arguing your point of why your study is important. Okay, so because when you're giving it to the publisher or the editorial board, your article, so it depends on how well you argue. So your literature review is very important to convey your peers that what I'm doing and why it is important, why it needs to be published. Then you should pose a formal research question or a state which you think that it's linked to this literature review. So this is how we go about conceptualizing our scheme. To sum it, a literature review should include an introduction, a summary, and a critique of the journal articles, the justification of your research project, and the hypothesis of your research project. So, so when we have done that, I'll just briefly go through, because it's basic. I think each one of the faculty and my senior professors and teachers all know this. But for the, I would like to bring out a general information to the students who have been doing, who's going to do a journal presentation or a thesis presentation for the first time. So what we use syntax, as we all know, the and, or not is the most important syntax we use, and it must be in the uppercase. And if you use an asterisk, like for example, if you're talking about allergy, you can just put an asterisk there. So it may give you both the results with an allergy as well as allergic. And sometimes if you want a double quotes, if you want for a phrase, then it has to be in the double quotes. So these are the various ways in which, if you look at PubMed, so these are the filters which we can use. So most importantly is when we look at, I think AU stands for author. After you write PUV or a posterior valve, and you write in a bracket AU, and a title is TI. Okay, TA is a journal, and then we can go for mesh terms or a mesh major topics. Like if you want to know only the major topics, or sometimes the subheadings in the mesh. So that's the MAJR, you can add it up. And other filters are like language, publication type, date. You can then, or if you want to know only about the author who has written about from the chronological order, so you can just write one AU. And then this is what I told. These are the most common tags which we use when we go about. The TW is one wherein we look at, if you are looking only at it, only when we look at the title, ABS, mesh, and some author keywords. and JUR is for the journal. So when we start about, we use the TI tag next to the word or phrase to limit our searches to the occurrence of that words in the title of a reference. And PubMed provides an additional tools to build this. So we will see that. If I have time, I will just go through and show you a live demonstration. So for example, if you look at what is the effectiveness of computer simulation training for endovascular procedures? So this is the heading which I thought. So when you do that, you can write, you can add up, as you can see, for simulation and TI, that's the title, and endovascular and TI. And if you want, you can add star for, so I said told you for stimulation, and if you want to go again for endovascular for TI, then you go and locate the reference for mesh by clicking it on the PubMed. Okay, so then so these are the various ways where we look at that computer stimulation for a mesh or a endovascular procedures. So this is in the you can see the double brackets, double phrases which were made. It will give you a lot of more topics to be done. Okay, so I would like to give a hint here for most of the things. For a broad search, we use the TW tag to target multiple fields when we use for a PUV with that. And this includes abstracts, subject headings, and author words and titles also. So like I told you that if you write simulation, you can write computer simulation, then bracket mesh, then or simulate star TW or a computer model with that, and so on. Okay, and then for the endovascular also we can add up the same way. Okay, when I go for the, I'll be telling you when you do that. So if I could put this all, this the third one, so the complete stimulation mesh and this still there, and go and type it in my PubMed, maybe I will get more articles or it will be refined to that. So I would like to add, sorry, is it time? So Vinay, is it time?
No, it's
sir, 3 minutes remaining, sir.
Yeah,
okay, sorry, sir. Thank you. So if you look at Prisma, so this is what preferred reporting items for systemic reviews and meta-analysis. So we have this is a recent guidelines in 2020. It was first analyzed in 2020 to 2009. I'm extremely sorry. And then we have the recent reporting items for this Prisma, which is basically a framework which is designed to improve transparency and reproducibility in systemic reviews and meta-analysis. So anybody who wants to do a systemic reviews, like using the literature review or a meta-analysis, the Prisma framework gives you what exactly you used to do. So I urge all the junior students and the junior faculties and those who are not into research to go first to this, and this will give you a nice schema there which will help you that. It helps in documenting the review process systematically and ensures the inclusion of all the relevant studies and the exclusion of irrelevant ones, and hence gives you a high quality of reviews. So basically in 2020, this is the summary points which I will not go into. So basically I would like to highlight that it consists of a 27 item checklist. Okay, so and it is also have a revised flow diagrams which I'll be showing in my next slide. So if you can see this, you can see that this is the previous studies what you have, and in identification you identify the records are being identified from databases and registers. Records are screened, reports sought for retrieval, and reports assessed for eligibility, new studies in the review, and reports of newly included studies. So basically total studies included in reviews and reports of total not included in the studies, sorry. And when you get that, so this is the final thing which you can get. There are a lot of automated tools which is available online. If you can use this Prisma, use your topic, and you can go on adding this topic to this, and then you can finally show it. Like for example, this is what I wanted to show. So this is the framework. First, when you start that, you go to this, and then if you get, you can exclude, or if it is not, it can tell it is not retrieved. It is there in the AI tools, so you can use that. This is all is the same thing. And in flow diagram, so where it identification, screening, eligibility, included, and checklist. This is what I told about 27 checklists. And these are the glossary of terms which, when you use the research method and reporting in the literature, these are the various types. It has already been spoken in the previous session. So if you can look at, this is the schematic diagram which looks at identification, screening, and inclusion. This is the Prisma flow chart. So if you can, if I have time, sorry, I'm not able to do that.
Sir, time up, sir, already.
Okay. So just give me 30 seconds. I will, if you can give me with a thing of the chair, sir.
Yeah, please.
Okay. So I'll just use 30 seconds here. I'll stop sharing my screen for a minute, and then.
Dr. Kiran, we will be very happy if you can show that advanced systematic search on PubMed. If you are
Yes,
able.
sir. I'm going to that, sir. Yes, sir. I am on that. So I'll start sharing my screen now. Is it visible, sir?
Yeah.
Sorry, I think. Yeah. Okay. So actually, I had made a search for post-urethral valves. So I will search it again. I think I applied filters. I'll change. See, because I had applied filters to show that clear all filters. You can go. I have cleared all the applied filters here. And if you have if you can make your account, if you can log in through your account there, it makes very important so that you can save this. Most important is because we do so many studies, so many searches. Okay, sorry. So if you can do that, see, we got 1,875. So here, if you can look at, this is a 120, see, it shows from 1921 to 2024. You can make sure that you can just use it in the last 5 years, as I told you. So there you can see the results would almost come down to 331. Then if you can go, then you can look at whether you're looking only at fixed articles, and then you can do that and see. It will come down to 328. And then next, if you want to look at the articles, if you look at a systematic review, if you only look at, if I want to look at a systematic review, it will be hardly 8 to 10 topics. 13 we have, okay. And at the same time, we can go on adding additional filters. And in the same way, if you can look at, you can go and save this. You can tell them where you want to save this and what format you want to save. You can save all relax, or if you want to search your thing, if you want to save it on PubMed itself, you can go and then you can create a file there. Else you can go to the advanced features in all fields. There you have a lot of, see, if you want to look only at the author, if you want to look at the first author, if you want to look at books, or you can look at mesh date entry, or you can look at the mesh terms or major mesh topics. If I do that, it will not come for posterior urethral valve because mesh topics are limited and it is very specific. So if I do that, I will show you it may not come. Okay, I'll just add this. Just to make sure that I'm just showing you that this will not work for a mesh term. So I'm doing this for this. So because it will show us that filters applied and all this. If you look at mesh major, no results were found. So basically, when you look at mesh, it has to be very specific when we do that. Okay. So, but if you add only, if you want to look at that PUV, and then you go back and you remove the mesh, you clear that, and you come back. So these are the various tools which is available in PUV in the PubMed, which will apply to show. For example, you can ask this best matches. So which I showed you in the topics when I told about endovascular and the simulation. So the various ways you can do that. So I think because this topic itself requires, maybe it is in 2 hours or a 3 hours way you can do it.
I think already we have crossed the time.
Shortage of time. I will be stopping that, sir. Yeah. And I would like to thank the IAPS, the whole team editorial board. I would like to thank Dr. Rasik Shah for giving me opportunity and providing this things to do. Sir, if you have any questions, you can go ahead. So thank you.
Thank you, Kiran, for a very enlightening lecture. And I think we have already crossed the time, so we can move over to the next session.
Thank you, sir. The next topic is the structuring of the manuscript and its content. The speaker is Dr. VVS Chandrasekharan, and the chairperson is Dr. Pradhanaya Bendre. Sir and ma'am, kindly take over.
Yeah. Thank you so much. First of all, hearty congratulations to IAPS and GIPS team for conducting this super informative webinar. And by now, every attendee has realized that how important it is to publish. Every institute in India has rich clinical material. And when we browse the world literature, we have seen that we are hardly seen there. So it is very important that our experience reaches whole world. And for that, structuring of the manuscript and its content remains the very basic and very important thing. Every reviewer, every article should be appealing. It should be scientifically written and should clearly convey and answer the research questions. And the trick is good writing the manuscript. And for this, I invite Dr. VVS Chandrasekharan. Dr. VVS, he doesn't require any introduction. If you start browsing the literature in pediatric urology, he is omnipresent. Many of the articles are there, superbly written, very scientific, very informative. So I cannot think of any better person than him to guide all of us on manuscript writing. Over to you, Dr. VVS. Thank you so much.
Thank you so much, Dr. Pandya, for a very, very great introduction. First of all, I think this is a great endeavor by IAPS. I congratulate Dr. Vikesh, Ramesh Babu, and Rasik Shah and all the others for thinking about this project. So I've been given the task of enumerating how to structure the manuscript. So I'll be very brief and I will make it slightly light so that these are all the research is very interesting when you do it, but it is very boring when you listen to how to do it. So basically, I'll try to just make it slightly light, but giving the required importance to the topic in question. So what are the various, we need to understand before planning how to write the manuscript, we need to understand what type of article we actually want to write. Because there are many types of articles which most of the journals accept, especially the surgical journals. They accept articles like technical innovations, how I do it, and all these things. So basically, so the format is slightly different for each of these. These information can be got from the journal's website, instructions to authors. But I will basically concentrate on the general format of writing an observational study or an original article. So that is the commonest type of article. So I will concentrate on the format of writing that article. So the basic structure of a manuscript, imagine you are telling a story. If I say Rama killed Ravana, I mean, nobody knows, unless, of course, we all know Ramayana, but otherwise we will not understand what I am saying. Who was Rama? Why did he kill Ravana? What was the reason? What was the mistake that Ravana did? So basically, the writing a manuscript should be like telling a story. So you are telling a story to a child. You want the child to understand the story. So you should write in such a way that you are telling, but of course, here you are telling the story to more educated people. So you should be more careful in telling these kind of stories, but the format is similar. So the IMRAD format, I think, has been already mentioned by Vikesh. As I said, some of the forms of articles do not have the same format. But for a standard manuscript or an original article, there are 5, 6, or 7 parts according to various people, but the basic parts are the abstract, introduction, methods, results, discussion, and conclusions. Sometimes conclusions can be slightly, considered a different last part, and finally the references. So this is an interesting, diagram which will show you the first 1, 2, 3 is basically introduction. So what we have is a broad start to the introduction, what is known of the topic, then what is unknown, how should the gap be filled. So basically we narrow down to the point of our research where we justify why we are actually trying to do this research at all. I will come to why we should do that. And the most specific thing is the methods and the results. So that is the narrowest part. So you need to remember that the methods and the results is the most specific thing for a manuscript. So that is a very narrow part because you only report what you have done and what you have found, as you have done and as it has been found. And then the discussion, of course, gradually expands again from a basic literature review to what you have found, to why you have found, and the comparison. And then the conclusion is again, the final part. So what is the sequence? Suppose I want to write a manuscript. What is the sequence of my writing? How do I write my paper? So I usually start with the aim. The methods and results are typically written first, because when I start writing a manuscript, I probably should know what the aim of my doing that particular study is. So I note down the aim, although aim is a part of the introduction. The last sentence of the introduction is usually the aim, but I usually write it down first. And then I describe my methods because I've used those methods. I describe the methods and the results, which, as we discussed, are the narrowest and the most specific parts of the manuscript. So they're specific, they're easy to write and no confusion, because you have done, you have done, you have not done, you have not done. And they're usually straightforward to write. And then based on these, the methods which I have used, the results which I have got, now I know what, so my aim is there. Have I fulfilled the aim with the methods and results? If I have not fulfilled my aim with these methods and results, then I probably will have to continue the study with a few more patients or a few more subjects. So I stop writing the article there and then I go ahead. But if I realize that with the methods and my results, I have fulfilled my aim, then I start completing the article and sending it for publication. That is when I start writing the introduction and discussion. I usually write the introduction before the discussion because the references are in the sequence, starting from introduction, going into the discussion. So if you write the discussion first and introduction last, you can do that, but then the problem is you'll have to juggle the reference again, which is going to be difficult. So then you write the introduction and the discussion. Discussion comes directly from the results. I'm going to go to that in specific again. And to some extent, the introduction also should come from the results, because introduction, again, the beginning of the introduction is very broad. I start writing about hypospadias. I can write about everything in hypospadias without reaching a particular point of hypospadias. So I need to know what my results are, what I'm trying to do, or what I'm trying to say through this study. Then my introduction will start there and then be more specific. Then usually abstract is typically the last to be written. So the introduction will be very brief about each of these subheadings. So this is an interesting. So you start with from broad and you come to a very specific research aim when you write the introduction. So you basically start with writing significance of topic in question, what is known, then what is unknown. If everything is known, then there's nothing you have to write about it. So what is known, what is unknown, literature review to support key questions. So you have to support. You can't say nothing is known about PUV. No, there's a lot that is known about PUV. So you have to, in posturathal valves, if you want to do some research, you have to identify what is not known or what is the controversial area where the answer is not known. And then you have to support the literature. You have to have literature support to support your quick questions. And the final sentence of the introduction is the hypothesis of the objectives of the paper that your paper wishes to address. So please avoid extensive literature review. I'm a reviewer to many journals, so I see a lot of articles where the introduction starts with an extensive literature review, which is not required and which is actually unwarranted. So the literature review, again, as I said, that is why the introduction should also come from the results and the methods. So from the results, the introduction should start. So you review only that literature which is specific and which is important for the results that you're trying to present. And then, clarity, the keyword, I've added one keyword for each of these subheadings. Clarity of thought is the keyword. By the end of the introduction, if somebody reads your introduction, if the reviewer reads your introduction, the reviewer should understand why you have done this study and what you are trying to do in this study. Then the methods. I think methods has been covered by Prabodh. I will just be very brief. So this is a clear description of what, this is the most specific part of the manuscript. So whatever methods you have adapted, whether they're adequate, inadequate, whether you have done them completely or you have stopped halfway because of various issues, you have to say all that and you have to be very specific to what you have done. The equipment, the study population, inclusion, exclusion criteria are extremely important. What was done? Typically, we are surgeons, we might do surgical intervention, how it was done. So your surgical technique should be very specific. How outcomes were measured, how data were collected and analyzed. Typically, I sometimes see papers where our experience with laparoscopic pyeloplasty. That's the title of the paper, and they discuss everything about their experience with 30, 40, 50 cases with laparoscopic pyeloplasty in children. In conclusion and the discussion, they keep discussing about open pyeloplasty and say open is bad. And then finally they say in the conclusion, they might conclude laparoscopy is better than open. You can't say that. So your methods have to be very specific. If your aim is to compare laparoscopy with open, that you have to specify in your methods, and you have to include a group of open pyeloplasty to be compared with laparoscopic pyeloplasty. So these are very important, and thorough description of all the above points is essential. Attention to detail is the key word here. Now, results, usually 3 to 4 paragraphs, the results. A description of what has been achieved or what has been found in this study. So a description of the major findings in the study, the measurements and data on the stated primary and secondary endpoints of the study, and results should be described as they are found. It is wrong to judge or interpret the results in this section. So in the results section, don't start interpreting the results. Our results with laparoscopic pyeloplasty are 99% success, which is very good or something. Don't start interpreting that. So you just say, this is what we have found. Then whenever possible and necessary, you can add tables and figures to show the results in much more comprehensively and clearly. And duplication of the same, the problem is you write the same thing in text and then you do the same thing in the table or the figure. It doesn't serve the purpose. It just wastes paper and duplicating the results. So you should not do it. And it is also important to publish some important negative findings in the study. It doesn't mean that all studies should only have positive findings. So even important negative findings should be mentioned. The keyword is accuracy. You should describe your results as accurately as possible. Then comes the discussion. The discussion, as I said, typically I write the discussion at the end after I've written my aim, methods, results, and I've written probably my introduction also. Then I come to the discussion. So typically about 5 to 6 paragraphs, you have to be because discussion is the lengthiest part of the paper. You have to be very careful that you stick to the word limit for that particular type of paper for that journal. Now, it summarizes the paper and puts the results in a broader context. Suppose you have found something. How is it important? How is your finding important? So you basically compare the results of your findings with similar past studies and discuss why they are similar or why they are. If they are really similar, there's no point in reporting it. Typically, there should be some additional finding in your study, which may be different from the other studies, which you need to report. And it should enumerate, the most important thing is, no paper is complete and no paper is flawless. No paper can provide all the information about a particular condition. So you have to enumerate the strengths and limitations of the study almost towards the end of the discussion, the last but one paragraph. And then in the last paragraph, based typically on the discussion, you can suggest some potential changes of practice if you have found something which can change the practice, common practice in that particular problem, or the prospects for future research. What should not be done is discussion from literature that is not relevant to the results of the present study. You are writing a paper on snodgrass, you write the entire discussion on onlay repairs. It doesn't work that way. Then overstating the findings of the study. So you have say 10 patients, your 10 patients have had excellent results, and you say that this is the best technique that is possible. So you should not be making these strong statements. So overstating the findings of the study should be avoided. So the conclusions, the last paragraph in discussion, you can actually make a subheading, or you can say in conclusion. You can start the paragraph as the in conclusion paragraph, and then you can complete the final summative statements that reflect the flow and outcomes of the entire paper. So the conclusion should come again directly from the results without any speculative statements. These are common mistakes I find in majority of the papers that I review for many journals. Then references, I think there is a separate talk on references. Basically, as I said, the references should start from the introduction and then go into the discussion part of it. And they are written according to the reference style. Each journal has a different style. And they should be recent, relevant, and reliable. And again, I'm not going into details about this. So basically, you should ask 2 questions to yourself before writing a scientific paper, or when you are actually writing a paper and you are maybe half through the paper or you're trying to complete, you should ask 2 questions for yourself. So what and who cares? If you can answer these questions satisfactorily for yourself, then I think that paper is likely to be accepted and is likely to be found a place in literature. Now, the abstract is probably the most important part of a paper and the most difficult part to write, because that is why I write the abstract at the end. It is a miniature paper. Basically, it's like Prezi writing. I think we all had these Prezi writing, competitions or Prezi writing questions in our school days. So that is where it is useful. You probably need to write a structured abstract for most of the journals, and it is very important to cover all the salient points within the word limit. So a good abstract should basically lure the reader to read the full paper. Many readers, including me, just read the abstract and then we may just not read the full paper. So a good abstract should actually lure the reader to read the full paper. The title, of course, is again decided mostly after the abstract and after the entire manuscript, and maybe after the abstract. It should be short, simple, convey the essence of the article, and capture the reader's interest. Again, writing a flashy title just to capture somebody's interest without substance in the article is not going to take you anywhere. A flashy title should also be followed by a very good and flashy article. That is when your title is going to make an impact. So this is again a mistake I see, that many authors seem to have decided the title before they write the paper, and that is when these problems occur. So the title can be a statement of purpose or a conclusion in the paper. For example, laparoscopic appendicectomy has lesser hospital stay or reduced morbidity than open appendicectomy in children. This is a statement. This is probably the conclusion of the paper. You can write it as a title. Or a question that is answered in the paper: is laparoscopic appendicectomy better than open appendicectomy in infants? It's a question. So basically, you can title the paper that way. Do I have time? Couple of minutes.
You need time up, sir.
Yeah. So one practical scenario, I'll just take 30 seconds on this. We wanted to write a paper on the laparoscopic management of PUJ in duplex kidneys, laparoscopic pyeloplasty and pyloureterostomy. We had 18 patients. And then we then asked our friend to get his patient. So we combined both our series, then became 25 cases. So the number is more. In rare cases, number is important. And then we realized from a review of literature that there's no report comparing pyeloplasty with pyloureterostomy laparoscopically. So we analyzed these two separately and then compared and got some interesting data rather than just writing our experience with laparoscopic management of PUJ obstruction in duplex kidneys. So we could, do a comparative study, and then we could get this kind of data, which probably is much more useful. Then a few take-home messages. Identify a question, perform thorough literature search, because a thorough literature search will also tell you how to write your paper. And then data is everything. Paper starts with the data and ends with the data. So it's extremely important. But correct analysis of data is also important. Just because you have data, it doesn't mean anything. You have to analyze the data in the correct perspective. before you write something, you should first read. Sometimes we see papers for review coming to us. The thing has already been written by somebody before. So unless you read, you will not know, and probably there is no point in writing the same thing again and again. So somebody interested can refer to this editorial of mine in JIAPS. I think I'll stop here. Any questions?
Yeah. Thank you so much. I think we have already short of time, and maybe you have to answer questions in the chat box itself. Thank you so much. And over to the organizers.
Thank you.
Thank you, sir. It was really insightful session. As sir said that correct analysis is important, that takes us to the next session. The title is Basic Statistical Analysis. The speaker is Dr. Ramesh Babu and the chairperson is Dr. Kirti Rathod. I would like to request that they take over now.
Able to hear me?
Yes, sir. We are able
Hello.
to see.
Able to hear you. You can go ahead.
Are my slides moving?
Yes, moving.
Okay. Thank you, Kirti. Thank you, Vikesh, for allowing me to talk on this. So before I go further, we need to know the types of data which we are dealing with. I'm not sure whether somebody has already spoken about it, but to set the stage, I want to say that we often have this categorical data. We do a retrospective study or cross-sectional study, and we report a success or failure, and we report it as a percentage. So whenever we say percentage, we are supposed to say what is a 95% confidence interval. I'll tell you why this is important. If you do 10 hyperspadias and you have one fistula and you claim that it's a 10% success rate, now if you work out the confidence interval for that, it will be like 0 to 40%. If you report 100 cases of hyperspadias and still report 10% complications, the confidence interval for that will be like 1 to 15%. But if you do 1,000 cases and still report 10% complications, then the confidence of that will be like 8 to 12%. So it narrows down how much you can say about a particular percentage you are claiming. Now, we often have this continuous data like a serum levels or uroflow rates, and we express them as mean standard deviation if they are normally distributed. And if they are not normally distributed, then we describe them as a median or interquartile range, and we use the non-parametric test. So I do not have time to describe about how to find out about normality of the data. There are a lot of tests, but a normal data, you should understand that it is in a bell-shaped curve, and a skewed data is not so. So what we shall see today is what is a confidence interval, how to compare two groups, to compare the association with either a chi-square test or Fisher's exact test. If you have more than an association, like a causal relationship, one leads to the other, then you look at the risk ratio or odds ratio. Then how to do students t-test, parent t-test, Mann-Whitney U-test. We'll all see practically about how to do this, but we will not see today about ROC curve, correlation, regression, survival, multivariate, forest plot, and funnel plot, because we don't have time. Now let me start with some examples. So this is a retrospective study, and they reported a success rate. This is a success rate of topical steroid therapy for phimosis. Rate as 50 out of 61, that is 82%. And so they have given the non-95% confidence interval as 70 to 89%. So how do you work it out? I use this GraphPad quick calc program. So you go to this confidence interval column of there, you enter your data, find that whatever number, the numerator and denominator, and then you click on the compute confidence interval, and then you get the actual percentage is 80%, and then 70 to 89 is the confidence interval. So that is how you do it. So now you have to sometimes do a chi-square test for an association. An association means, I'll give you some example. For example, males and female and the smoking. So having particular sex is not a causation. So you call it an association. Smoking among males, smoking among female is an association. Similarly, if you have lung cancer in male and lung cancer in male, usually it is an association and not necessarily a causation unless they are genetically predisposed. But if you look at smoking and lung cancer, then that is a causation. So the causation has to be tested with the relative risk or odds ratio. Whereas if it is a simple association, you can do a chi-square. So for a chi-square is the commonest thing which we do. So in this paper, postoperative steroids in boys with histologically proven BXO, and they looked at this meatal appearance, abnormal meatus, normal meatus. Then whether they warranted postoperative dilatation or postoperative dilatation. Now here, I don't see any causation. They are just looking at the meatal anatomy and then see whether they actually need the dilatation. And they looked at these numbers, 3 out of 24 and 6 out of 90. So they are comparing basically 2 percentages. It appears that, double the number of these people have with abnormal meatus have a needing dilatation. So how do we do this? We have to do what is called a 2x2 table. And when you do 2x2 table, you have to remember, you don't enter 3 and 24, but you enter 3 and 21, and then the total is 24. Similarly, you have 6 and 90 here, so 6 and 84, and then you get the total 90. So how do you do that? So here, it depends on, if one of the values is less than 5, then you have to go for Fisher's exact test. So this is how they have done it. They have done 3 out of 24 and 6 out of 90. So how they do it, you go to, again, GraphPad, Fisher's, do 2x2 table. I'm going to show you basically how you do, because a lot of PGs don't know how to do it. So you enter the actual values like 3 and 21 and 6 and the other column outcome. So then the Fisher's exact test is chosen because one of the values is less than 5. So you click calculate, the total number is automatically worked out there, 24 or 90. And so this is a not significant, so 0.3. So although it appeared like a significant difference, so by doing this statistical analysis, Now there's a cohort study and a case control study. I would simply introduce this to you. A cohort study is where you have 2 groups, you have 2 exposures, and then you look at the outcome. For example, you look at all the smokers, all the non-smokers, and you keep on studying them for years together, looking for lung cancer. So that takes years and years and years. So that is when you look at the relative risk. On the other hand, you look at cases with lung cancer and the controls without lung cancer, and then see whether they are smokers. So you're basically doing a retrospective or going back. And that is when you look at the odds of a cancer patient being a smoker is found out. So the odds ratio is the ratio of odds of the exposure in the disease, whereas relative risk is the risk of disease in the exposed group, also known as risk ratio. Now, I'm not going to tell the details about the formula, but entering the data, how you enter is important. So you get the disease or the outcome in this place in the top. So that is where you enter the disease. And you get the exposure or the risk here. For example, if it is a smoking, no smoking, cancer, no cancer. That is how it is. On the other hand, it doesn't mean that the disease is there. For example, you are looking at the BXO, non-BXO, stenosis, no stenosis. So the disease has come here, but the disease is the risk here. And then the outcome is the stenosis. So you have to really think what you're basically doing. Only when you get the A, B, and C, D correct, you will get all your values. For example, this is the study where they looked at bleeding after circumcision, and they said it's more likely in children with the BXO. So they looked at BXO and non-BXO. This is the exposure, and this is the risk, bleeding or no bleeding. So they followed up all these patients, and then they found that this is the risk. So it's a huge numbers here. So how do you work it out? So you go to the risk ratio calculator and then see what happens. And you enter the data. You have to first define what is in which column. So A, B, and C, and D. And as I said, don't put the total there. You put the outcome, the bad outcome and good outcome. And then you go for the test. And these calculators try to work it out based on the formula. I mean, we all know the formula, but how to work it out using the calculators, that is the practical way. And the relative risk is 6. That means 6 times higher risk of them having that particular problem. Now, this is another study where they looked at the obesity being a risk association with the BXO. So here, they looked at BXO patients and no BXO patients and went back in history to see what is their BMI. So this is basically an odds of a BXO patient having a BMI more than 95 versus the odds of a non-BXO patient. So here we are looking at the odds ratio. How did we get this odds ratio? That odds ratio is 5. So again, we go to the calculator. This is the MetCalc. I mean, a lot of calculators are there. You don't have to use this. Here again, you have to make sure that you get the right boxes and right numbers. And then you have exposed group or non-exposed group. And then you look at it. And that is when you get the odds ratio. So you should be able to calculate all these ratios based on what data you are getting. Now, mean and standard deviation, a lot of people find it extremely difficult to do the simple thing. You have an Excel sheet, you go to you enter all the numbers and do the average, and average is the mean. And then you go to the same thing, and then you go for more functions and enter the STDEV, standard deviation, and that is how you enter the standard deviation. So this is very simple. All of you should be able to find out mean and standard deviation yourself. Now I'll just look at this paper. This is our own paper, ballooning of foreskin and physiological phimosis. Is there any objective evidence of obstructed voiding? So this was published nearly 20 years ago. So basically this is a comparison of Euroflow rate, which is a Qmax. So in boys with the ballooning 18 and boys without ballooning 14. So the mean Qmax and within bracket is the standard deviation. So how do you see whether that is different? So again, you go into this quick calc. Here you look at the continuous data where you have the t-test, student t-test. So here I'm going to use the t-test to compare two means. And then instead of entering the raw data, I'm going to choose enter mean, standard deviation, and number. And then you enter the details one by one. So whatever mean we have calculated from the previous Excel table, we enter here. And then the standard deviation and the numbers in each group we enter. And once we enter, we know that we can calculate this. And then when we hit the calculate, we know that what we get, this is 0.07. No, the p-value is 0.9. That is not statistically significant. So we know that it is not significantly different. That is how you do the mean test. Now, paired t-test is different because each one is a similar group. For example, this is a patient before tacrolimus and after tacrolimus. This is the Euroflow rate before and after tacrolimus. So here you cannot compare like that because they are all paired group. So ideally you should use a SPSS for this. So you enter the details in an SPSS before and after tacrolimus. And then you go to paired t-test and then put them into different boxes before and after. And then you hit, you can choose options if you have options to produce different data, but you generally hit OK, and then you get that. And the data set that be the difference between before and after, and then you get the significance at some point there at the end of it. So you will know that there are a lot of things to come. The significance will also come there. It is just come out of the screen there. But that is when you get the significance of that comparison. Parity test. Now, Mann-Whitney test is a non-parametric test. Basically, we are looking at the number of dilatations needed in no BXO versus BXO. So this is a skewed distribution. So we have to use a non-parametric test. So we use the SPSS again. So here instead we go to non-parametric test. So independent samples, then we go to this independent sample non-parametric test, Mann-Whitney U. So we put them as different. So the outcome is like 1 and 2. So we have put it differently. And then we ask for the SPSS to give the data. So that gives us the Mann-Whitney test for non-parametric test. Now, sample size, Prabhu has already spoken in a big way. So the sample size depends on the difference, what you're trying to see. For example, open versus lap reimplantation, you are comparing. So the open reimplantation success rate is 95 and then lap reimplantation success rate is 80. Then you probably get a sample size like 75 in each group to see the difference. Because the difference between those two groups is around 15%. You change the same thing. For example, you are comparing open versus lab pilot plus. Now the difference is only 5%. So even the number has become like 400. So the smaller the difference, you need a bigger sample. So I will stop. Now I'm going to ask some real life situations. So may I ask Hira to unmute and then answer some questions here so that people can understand? You there?
Yes, sir, I'm here.
Yeah. So this is a river trial, antimicrobial prophylaxis for children with vesicular reflux. So basically what they did was the children with VUR were followed up with the continuous antibiotic prophylaxis or placebo. So the outcomes were febrile UTIs. So 39 out of 302 patients who had a CAP developed febrile UTI, whereas 72 out of 305 who had a placebo developed febrile UTI. So what type of studies can you tell us?
Yes, sir. So this is a cohort study where the study group here is children with VUR. Here the exposure is one is CAP and the other one is the placebo. The outcomes looked at were the febrile UTI.
In the first group, for example, in the continuous antibiotic prophylaxis group, 39 out of 33 not to develop the this UTI. So what is the, how do you work out the confidence interval in that group? What is the confidence interval?
Yes, sir. So I'll use this graph pad.
Okay.
So
here
the...
So when you
Yes, sir.
So when you use that, it comes out like this because the numbers are quite big.
Yes, sir.
So this is what it comes.
9 to 17%.
So what type of statistical analysis is appropriate to compare these two groups? You want to develop the CAP versus placebo. So what will you have the comparison? What kind of statistics?
Relative risk we can calculate to see the causal relation.
And when you do a 2 by 2 table, what are the values to be entered in each column, each row? Can you tell that?
Yes, sir. So the we have a 2 by 2 table. In the row, we have to enter the exposure. So here the exposure 1 is CAP and exposure 2 is placebo. And on the column side, we mention the outcome. So outcome 1 is febrile UTI and outcome 2 is non-febrile UTI. So A will be children with VUR who had developed febrile UTI following CAP. So that will be 39. And B is the remaining. So 302 minus 39, that will be 263. And C is in the placebo group. So that is 72. And the remaining will be 233. That will be D. So
C is 0.5 here. So
yes.
What is your interpretation of that?
So the interpretation is the risk of getting a febrile UTI is reduced by 50% after using CAP.
So that is how you should understand a relative risk. Now I'll just give another small sample before finishing. So this is a QT trial, a branch of river trial. So association of renal scarring with a number of febrile urinary tract infections. So children with VUR were divided into two groups, scarring and no scarring. And then they went back and recorded the number of febrile UTIs. So 35 children who had 2 febrile UTIs, and then 25% of them developed a scar. And 246 children had 1 febrile UTI and 2.8% developed a scar. Now, what type of study is it?
This is a case control study.
Yes. So you can cause case and control or two groups. So the one with the scarring is a case and then no scarring is control or something like that. And what type of statistical analysis is appropriate here?
Odds risk we calculate here.
Odds ratio. So again, this is the way you construct the 2x2 table. So you enter your data. So here the exposure or the risk is the second UTA and first UTA, and scarring and no scarring. So the diseased one comes on the top. So like smoking and lung cancer, this is where like second UTA and renal scarring. Now here the odds ratio has been worked out as 11.8. So what is your interpretation?
The odds of getting a scarring following recurrent UTI is high.
This is kind of like when you add both this QT trial and the river trial, you have that, the risk of second UTI causing scarring is very high, and the risk of a continuous antibiotic prophylaxis reducing the recurrent UTI is high. So there is an indirect evidence to say that continuous antibiotic prophylaxis will reduce the scarring. So that's about it. So we'll stop here, and then we'll take questions or comments from audience. Kirti.
Thank you, sir. Excellent presentation with real examples and simplifying the difficult statistics part. Any questions from the audience? No questions.
Want to add any points, Kirti? So statistics is not difficult. That's basically what I want to stress. Anybody can learn. Definitely the basic statistics, we do not need statistician. Anything higher the regular statistics like survival graphs, even survival graphs we can do. But for that kind of correlation, regression and all those things, we will need a statistician, but not for this regular day-to-day work. Thank you very much.
Yes, totally agree. Comment, sir? Kirti, can I?
Yes, please.
Yeah, as Ramesh Babu sir said, all of us need to learn basic statistics. And it is very easy to perform statistics nowadays with so many softwares available online. So unless we start doing it, we will not learn it. See, watching these videos and these lectures will make you realize that you can do it. But unless you do it, you put the data yourself and get the results, you will not be able to learn it as well as interpret it. So start doing it. See, all these talks are important, but unless you apply it in your practice, you will not learn. This is what I wanted to say. And most of our statistics work. Nowadays, most of us, we do it ourselves. Except complicated statistics, we take help of biostatistician. Thank you, sir. Thank you. Very nice talk, sir.
Thank you, sir. It was an interesting session with these real-life examples. Now moving to the next session on interpretation of results and illustrations. The speaker for this session is Dr. Kanishka Das, and the chairperson is Dr. Sanjay Rao. I would like to request that they take over now.
Yeah, thank you very much. It's a pleasure for me to introduce Kanishka. He's a well-known teacher within our association and is an academician to the core and a very, very lucid teacher. So I will hand it over to Kanishka to take on this session forward. Kanishka, thank you.
Thank you, Sanjay. Am I audible?
Yeah, you're audible. You're audible. Please go ahead. Slides are visible as well.
So yeah, some of my material has already been covered by the previous speakers. So at the relevant points, I will just skip them. So as Chandrasekhar said, results should actually follow very logically from aims and methods. And it should lead the reader in a flow of thought into discussion and conclusions. They should be interlinked to each other and should not appear discordant or contradictory to each other. It's best to classify your results as you write the results section. So the general findings are first, and you funnel it down, as mentioned earlier, into specific details, so that you leave the reader at the end of results with very specific details that you have encountered in your research study. The content in the text and illustration should be complementary, not repetitive. one can just complement the other, because the repetition is only going to waste journal space and waste your space to put forward more facts and thoughts. It is a common mistake to sort of read more than an evident into the results and over-interpret results. So one should abstain from that. And of course, tests of significance are stated in the results, but do not go into interpreting them. Leave that for the discussion. Right. So illustrations may not be required for all sections, but it may be required if you want to offer very precise and crisp visual information to supplement the text. It may also be used to reiterate a very significant cardinal fact that you are mentioning, and not just to repeat information in the text. The simplest illustration that would suffice is chosen to communicate, and it is integrated with textual flow of communication. You give a reference to that in your text, running text, and see during editing that it is placed appropriately for the reader. And the legends are, of course, crystallized details which are placed just next to the illustration. So we will go through common illustrations that we use. Clinical photographs are taken with consent and anonymity. Anonymity is ensured. It begins from planning in taking the photograph, wherever you are taking it, with lighting, background, detail, clarity, etc. A scale may be included if useful for comparison. And editing helps. You can use various programs which are available nowadays, and labels and markings appropriately. A composite clinical photograph packs in a lot of information and gives an economy of space. Legends accordingly. So just to illustrate, you can see so many pictures here of a genitalia with a prominent clitoris, and there's a mass somewhere in the thigh. So this is from a paper which illustrates a synchronous adenocortical carcinoma with genital hypertrophy and a rhabdomyosarcoma at the same time, looking into the genetics of that. So from these pictures, the author has narrowed to these two, which best show it with appropriate background lighting, and then further down taken it to a more composite picture so that you can illustrate the thigh mass correspondingly in the MRI and the adrenal mass. Similarly, imaging, there's a range of illustrations. We choose the best and the appropriate illustration, like an MRU is the best rather than IVU for a duplex system that you want to show with clarity. Capture images at every opportunity that you find in your clinical practice. And if you can get the images from the electronic system rather than take from a view box, they are preferable. But classify them and index, because you will have soon thousands of pictures without any classification and index, and you won't be able to retrieve them when you require. And in complex imaging, you must involve an imaging faculty and acknowledge them, just like for a photomicrograph, we involve the pathologist and acknowledge them. To give you an example, this shows case of dextrogastria. So there's a mid-gut rotation and a foregut rotation, malrotation. Just to illustrate that before the surgery and after the surgery, if you leave the pictures like this, it doesn't give you the correct information to the reader. But if you mark appropriately, showing the levocardia, the dextrogastria, the arrows in plain X-ray and the corresponding thing in contrast, so that the reader can see the comparison and go through your simple legend, it gives him a clear idea. Similarly, he can see the pre and the post-op next to each other and compare how the things have changed in the post-op contrast study. So all depends on how well you label it without obscuring any of the facts that you want to show, with neat small labels, small arrows, and then correspondingly give a neat or a crisp legend. A more complex illustration showing ureteric jet Doppler waveform. This is where we may not be suitably equipped, and the radiologist will help us with the correct frames and the correct description that go with these illustrations. Clinical radiological illustrations can be made, again, to match the clinical appearance and side by side the imaging. So here you can see an ultrasound of a tumor in the periurethral area preoperatively, marking the various corpora, etc., where the tumor is or the mass is, and in two sections. The same picture is repeated post-operatively after it has been excised to show you that it is no longer there and what is left behind and whether it is a complete excision. So operative photographs. Personnel and the camera should be ready all the time so that you capture moments without losing them. Now with digital cameras, you can take a number of pictures than what we were doing earlier. All yes to clean field, a neat background, various shots, and use instrument pointers. No to bloody field and hands and fingers in the field. Endoscopic views are taken best with high fidelity captures from the camera. You may take them from the screen as a lesser alternative. Edit and compose them so that you mark the relevant structures. For example, here you can see the liver there, the stomach in dextrogastria, and the arrow is actually pointing to the greater curvature so that they identify the layout. Since we don't have the DJ in view to tell us that it is midgut malrotation, we have used a surrogate position of the appendix there just to indicate. So you can only show what is there. You cannot show beyond that. An endoscopic view of the neurofibroma that we saw, which is protruding into the urethral lumen. Use your arrows justifiably so they don't obscure your features. An endoscopic view of an overtesticular DSD, a diagnostic one. Mullerian structures and the overtestis that is seen. Surgical field illustration and imaging fields can also be kept next to each other for comparison. Here there's a retroperitoneal cyst and the same thing in intraoperatively for them to compare and correlate. Pathology, Ross and microscopy play a very important part. Fresh specimens are different than fixed specimens. You would see illustrations of that. Important to keep a track of gross and microscopy illustrations and the rules there. You may use composite illustrations to specify features that you want to lay emphasis on. Again, it is important to have scale, particular scale, the magnification, and label your features so that the uninitiated may understand. Just to illustrate, a fixed photography, fixed specimen, and a fresh specimen. They convey different meanings and they can be put together for the reader to understand. This is a large tumor where you want to illustrate the IVC. You can mark it as a groove to show how the IVC was encased. But of course, here the emphasis of this paper was on the small cell, the epidoma, epidoma, the thing. And so here, if you look at these pictures, this is not the best of pictures because you have little things written here and there. So a better picture would be something like this, where you compose them together, enlarge, take the relevant field and give a neat a composite picture with what you want to stress. Give more space for that, what you want to stress. Similarly, combination of gross and microscopy, there's a mixed malformation of a sequestration and a congenital lobar emphysema. Again, microscopy shows you features of both. Inset highlights features that you want to lay emphasis on of both the lesions in one field, and a scale is appropriate. The pathologist is going to help you with many of these IHCs, which are the rule of the day besides molecular techniques, because they need appropriate interpretation, marking, and legends. So acknowledge them and use their expertise. Tables, charts, flows, and graphs. You can present comprehensive details or you can present summary of clinical details. Both are as important. When you use flow charts for methods of management or a meta-analysis like the Prisma, again, that is where it is useful. Graphs to illustrate results, trends, and statistical concepts that emanate from your paper. With all this, keep it simple and explain the difficult terms because the person at the other end need not necessarily know all that you are saying. So just to show you, this is a comprehensive table of cases of TCA, but then what is important is a case profile like this, which gives a summary of your 22 cases at a glance and the relevant statistical figures so that they know what the panoramic view is like. Similarly, if you want to stress on something particular, use highlights and use simple subheadings and sub-subheadings so that they identify that you are looking at one or two particular concepts and stressing what is significant, what is not significant, where data is not available, acknowledge it is not available. I have put this from one of our publications to show that even after you have done all this, you might miss things. Look at the font sizes, they differ and they do not apply to the scale, same scales do not apply. Such things should be avoided during editing. So what is new in your paper? I will conclude with last 2-3 slides. You may use various means to emphasize that. A summary figure or table, as some journalists advise us now, a message box, or an illustration of a management or a new technique. But be very convinced and armed with data to push your concept. So this is an example of a summary figure from Journal of Pediatric Urology, where we have said that you may retain the refluxing lower ureter stump to be of use to preserve a solitary kidney function. So this is what is going to capture the roving reader's interest and draw him to your paper. So it's bare facts and figures, but in a very simple manner. Similarly, this is another thing where you want to push a new technique of performing. Let us say this is a donut in Hirschsprung's, and we are looking at the histology, trying to show the ganglionic, aganglionic irregular interface and how histology helps. Again, giving the histology, histochemistry to prove your gross. So again, this is showing translation is feasible. You want to propose a new technique, be very careful with the illustration so that the new technique is amply understood by the reader. Here we are trying to suggest that you can do a pylopilostomy instead of other procedure for a crossing lower polar vessel. New things are always met with resistance, but if you dish them out appropriately and they are going to be translatable, they will stand the test of time. So in summary, follow realistically. Results must follow realistically from the methods and lead into conclusions in a flow of thought. Illustrations where used are chosen carefully and packed with information relatable to the text in the manuscript. And choose your figures, presentation, and text depending on the audience or the readership that you want to reach out. Thank you.
Thank you, Kanishka, for a very lucid, very brief, and to the time presentation. There is still about a minute and a half left. I think a couple of comments I shall make, and if there are questions from the audience. As is rightly said, I think you have illustrated a picture does speak 1,000 words. I think there are a few additional things. I think putting things and presenting data comprehensively in tables probably also allows this paper to be tapped for further systematic reviews and meta-analysis. So it encourages citation of your paper. So I think presenting data in composite tables is very important. Similarly, having good photographs, good graphs, again, allows these things to be picked up by people for their respective publications and increases citation index. One common mistake that I see is information and photographs being transmitted via WhatsApp. Somebody takes a photograph in theater with their mobile phone and then sends it by WhatsApp to somebody else to publish. Now, the problem with WhatsApp images is it seriously downgrades the image. It's good to see on a phone, but if you're going to print, please do not transmit images by WhatsApp. I would suggest that you please email full resolution images so that they can be processed for publication. So these 2-3 things from my side. We still have a few minutes, so I can open it for questions or comments. I don't know if there are others. If I'm audible,
Sir, can I make a comment?
Yeah, please go ahead.
Yes, sir. Very well appreciated point that we should not be transmitting these operative and other pictures on WhatsApp, and those that are transmitted on WhatsApp should not be used for presentation. So there's a recent development. WhatsApp has now introduced the feature of transmitting photographs in high resolution. So that is one way which can be used. I came to know about this high resolution thing just 2 days back. And otherwise, another way which can be resorted to if it is ultimately mandatory for some reason. So transmit the photographs on WhatsApp, not as photographs, but as files. So like you send documents. So you use that option to send a document, but once you are into the Finder, navigate it to your photograph folder and select the photograph instead of the document. So it doesn't lead to loss of resolution. And otherwise, what you said, send on email is an absolutely wonderful idea. Thank you, sir.
Thank you. Thank you.
Even
So I think
Sanjay, even
yeah,
you can
yeah, go ahead.
transmit it the HD photograph, you get an option. Even on WhatsApp, you get an option of HD transmission.
Okay. All right. Thank you, Kanishka. Thank you for this very lucid talk, and thanks for the organizers to having me here. Thank you very much, and I'll hand it back to the Master of Ceremonies. Thank you.
Thank you, sir. The next topic is writing the discussion and identifying limitations. The experts are Dr. Arvind Sinha as the speaker and Dr. Simi Ratan as the chairperson. I would like to request them to take over now.
Everyone. First of all, I have to congratulate the IAPS team. Much needed workshop, at least, creating the awareness about its need. And we are going through serially into the sequence of paper writing. And we have reached the stage of discussion and limitations. I think discussion is the most important and key part of any paper and manuscript. And most of the problems the students they find is in writing discussion, because it's the point where we are analyzing our research results and trying to discuss it point by point. And in light of the existing literature, trying to fill up the knowledge gaps. And limitation, definitely we have to be that truthful to see which field our research lacked into and how it can be improved with further research. So I invite Dr. Arvind Sinha, who is the professor and head Department of Pediatric Surgery at AIIMS Jodhpur, to throw light on these important topics. And this is really, really crucial for any paper or for any manuscript. Dr. Arvind, please start the...
Thank you, ma'am. Ma'am, is my slide visible?
Yes, it is visible.
Okay. So I think we've gone through the whole gamut of the introduction, the material and methods, the study methodology, the statistical analysis. Now, once the results have come, photographs have been put in, the time for discussion and limitations, as ma'am rightly said, starts, right? So introduction basically is, why did we do the study? Method is, what did you do? Basically, you document what you did. And results is, what did you find, right? Well, once we've done all these three, then there's the time for discussion. What does it all mean? It basically ties everything together in a neat bow tie and presents it to the world, right? So this is what discussion is all about. Right. So what's the importance? It basically gives the meaning to the study results, the implications of your findings in the context of your study, and it also allows the researcher or the author to give his interpretations and propose some hypothesis, right? So what are the components of a discussion? If you look at a discussion, what are the components? How do you start the discussion? Basically, start off with the summary of findings. What was the critical findings that you found? And then the second part is the discussing your key points. You cannot really discuss everything, every finding that has been seen in your results, but you basically find the key points and discuss those key points. And then, so you discuss what can be said about your findings and limitation of what cannot be said about the findings. So in the limitation section, you answer anticipated criticisms, and then you go on to the conclusions and limitation. As Dr. VV has pointed out,
Yesterday I was going, no, evening, units
Dr.
standing here.
As Dr. VV has pointed out, that you do 10 hypospadias patient, you cannot say that the results have been wonderful, right? So extraordinary claims require extraordinary evidence. So you need to have the results backing up whatever you are claiming, right? So how do you create a compelling argument? Basically, if you have to start the discussion, I suggest you go back to that is the conclusion. What is the conclusion of the study? You start with the why. Why are you writing this paper, right? If you have the clear idea of why you are writing a paper and narrow it down to one or two or maximum three key findings which are driving towards your conclusion, I think most, at least mentally, your framework of the discussion would be ready, right? So first step is basically to answer the why you are writing the paper and what message are you trying to give. This should be absolutely crystal clear from the beginning till the end, that is the conclusion. And many papers I've seen have the lacunae that they discuss everything under the sun, whatever results are there, those are discussed without actually getting to the point. You have no clear idea what they are trying to say. Right. So how do you find the key findings? In retrospective studies, it may be obvious, right? You have a certain idea and that's why you started the study, retrospective analysis. It may be very obvious why you're writing the paper. If it is not obvious, let's say in a prospective study, you basically go through the results, go through the tables and figures and outliers or differences from literature. These are easy key points to pick up on. If you still don't find your key points, key compelling arguments, then if you look and read a few 4 or 5 articles around your topic, you with some immersion, I think you would organically come up with an argument for your paper, right? So how do you start writing? So you start with the conclusion, the why you wrote the why you are writing the paper, and then start off the writing of the discussion portion. So how do you start writing the discussion? One of the methods is to give a statement about the setting the stage. What is the basic background of the topic? 1 or 2 lines, nothing more than that, and introduce the key question that needed answering from the introduction itself, right? Because if, especially for lengthy article, people forget after going through all the thing, but why you started off with the study itself, right? But it's important to be absolutely brief. Nobody wants a rambling discussion as such, right? So let's look at a GIPS original article which was there from Ames Patna about informative videos for proxy contents by parents, right? So this is the first portion of the discussion, and they basically started off with. Oh, right. The first line highlighted in yellow or orange is this: anxiety is compounded when they have to sign a consent about something which they know very little about. So this line basically sets the stage. Sets the stage for the discussion to follow, and next thing is why the study was done. The line highlighted in blue basically says a study on pediatric inguinal hernia consent found significant lower anxiety scores in parents after consent videos. However, randomized control trial did not show any benefit. So this is where they have identified why this study was done, what are the lacunae in the existing literature, and why this study was done. Is there any other way to write the first paragraph? Yeah, because no one would want a rambling section of setting the stage or rehash of the introduction in the discussion itself, right? The alternative is just to give the key points in the first paragraph, the identified key point that you want to highlight in the first paragraph itself, and this is the most direct way, right? So let's look at another article, percutaneous internal ring suturing for inguinal hernia. The first line states the study reports the long-term outcome of children who underwent PIRS for inguinal hernia. This is why they did this study. And the second line they give, our results demonstrate that PIRS is both safe, highly effective with low recurrence rates and minimal complications, right? These are the key points for which the study is being published, right? So they've started off in your face that this is why we started off the studies. So that's another acceptable way to start off your discussion itself, right? So we know we've started off with the conclusions, why we did the study, and first paragraph where we set the stage and gave the key points about our results, right? So what forms the body of the discussion? What do we discuss here? let's go on to it. We discuss in the body of the discussion, we discussed 2 or 3 key points, critical key points that we should discuss. And if you have 2 or 3 key points, which point should we develop further first, and which point should we develop subsequently, right? So more general to more specific points. You should go from more simple to more complex point, descriptive statistics first, and interpretive analysis later, right? And you may use adjectives and qualifier like it is technically easier, parents were happier. Those kind of arguments, those kind of statements, discussion, right? So you've identified the sequence of the points to discuss. So how do you develop a point? So you've got 2 or 3 points, you develop the sequence. How do you develop a point, right? That basically would form, let's say, a paragraph in your discussion, right? So the first portion of discussing is actually to state what your results say. So describing the state or the point or the result that you're highlighting, right? And second step is to juxtapose that point against the existing literature, to compare it with the existing literature. And the third point is basically to explain why the results are what they are, right? So is the result comparable? Is it not comparable? What is the difference? Why did you achieve that kind of result that you achieved? And fourth is the interpretation of the results, your opinion, your spin on that point, right? So let's see an example. Suppose you do a study on open hernia repairs and you find a 5% incidence of scrotal edema. That would form basically the first line, right? And then you would want to compare it to existing literature, and let's say you write a recent meta-analysis suggested a 6% incidence, right? So you basically say, yes, our results are comparable to world literature that is available, right? And the third line could probably be, it's probably due to a large dissection of the inguinal canal, which is often required for open inguinal hernia repairs, right? So that is the explanation for whatever results that you have got, but you want to give your opinion on whatever results you've got. So the fourth line could be it was mostly self-limiting, resolved in, let's say, 24 to 48 hours with no complaint, no incidence of discomfort to the patients itself, right? So this is the interpretation part of the developing a point, right? So let's look at another example, the same example, percutaneous internal ring suturing for inguinal hernia repair. The line marked in yellow basically says we observed 8 complications in 6 patients. Complication rate was 0.84%. So this is the factor which discusses the results. The second line, this line subsequent is highlighted in blue. In a comparison, 1827 patients undergoing open and repair, Safa et al. Reported a complication rate of 5.1%. So this is basically comparing that result which we have obtained against the existing literature. The third line, which is highlighted in green, we observed a range of complication in our patient, primarily vessel puncture. So this is the exploration of the results or explanation of the results that we have seen. And the fourth line is the interpretation, that what is our opinion, that yes, we've got 0.84% complication, but only one serious complication was seen, that is omental evisceration was observed, right? So this is the way you develop the point. So basically each point should form one paragraph, or if it is a critical point, probably 2 paragraphs, right? So similarly, again, another article from GIAPS by Dr. Weber, he did impact of dual coated silver nanoparticle and antibiotic sutures and wound healing and inflammatory mouse models, right? So he's got 3 critical points. You will see he's developed the first marked in black, then the marked in blue and red, right? And you can see the challenges in innovation in suture coating is the first point, and synergistic effect and wound healing in the second, and immunomodulatory properties in the third. And what you can see is all these points are basically funneling towards your conclusion, the why you did this study, right? So all these things are funneling towards. So everything should come down to why you have done this study. So each of these critical points gives a line in the conclusion. It basically leads to the conclusion, right? So this is what I want to highlight, is each
point should lead to conclusion. You should not have any extraneous matter coming in to your discussion itself. So just focus on your key points. Do not divert, do not loiter, right? So one of the articles which I like extremely is this article by Nigel Hall, Southampton, UK 2024. It was published, which talked about minimally interventional approach to esophageal atresia repair. They don't want to talk about results and all that, but minimally interventional approach that they follow. So they had 186 cases over 80 years with excellent results, right? But if we would have done it, we would have talked about, let's say, birth weight, we would talked about complication rate, operating time, date of presentation, complication rate like leaks, GRs, follow-ups, and everything. That would have been the general idea to discuss that. But their approach was that we have to talk about minimally interventional approach in esophageal atresia. So what they said was results speak for themselves in the results sections. Since they are not the cornerstone, they did not discuss the results at all. They only focus on highlighting the minimally interventional approach, that is avoid chest drain, avoid routine contrast study, start oral feeds early, and avoid central catheters. And the results are speaking for themselves, right? So they used the results to drive home the point that they were trying to make, right? So they did not discuss anything extraneous. It was a very focused article, only 10 odd references for 186 patients with good results. Like in 300 movie, King Leonidas said, remove everything that distracts from the spear throw, right? Then once that discussion is once your discussion is completed, your key points have been developed, you have to talk about limitations. It's a mandatory part of the discussion. It's often a tightrope walk. You have to identify the shortcomings in your own research, but you should not be so critical that you undermine your whole study. So in conclusion was the conclusion and your message should still be left standing after you've done criticizing it. You cannot poke so many holes in your study that your conclusion actually becomes worthless, right? So your conclusion and messages should still stand, right? So it's often distressing for many to write, and it's often left for the end, and it's often an afterthought for many of the authors, and it definitely can have a detrimental effect on your paper. But I think we should use it very positively. This is the place to answer anticipated criticism. Let's say imagine your worst critic, and whatever criticism he might have, you can answer that in your limitation sections, right? So this is the place to answer anticipated criticism, and in fact you can give yourself some backhanded compliments also in the limitation section, right? So various you can identify it in the various sections like research scope, design, data collection, external factors, but don't try to punch holes in every facet of the study, right? So research scope and design, whether it is generalizable study design, sample size, data collection method, whether they're missing data, whether observer variability was there, operator variability was there, external factor like a time constraint especially for thesis and all that, you might have a very small time constraint. So those can be highlighted in the limitation section, and you can actually reflect on the literature and context that you can identify comparative gaps. Right. So let's look at examples of limitations being used in papers. This is a paper from JPS which talked about intraoperative and postoperative pain in patients undergoing inguinal herniatomy, and they said that they use general anesthesia and caudal epidural block. But the thing highlighted in yellow is hence our findings may not be applicable to other methods of anesthesia. So basically in their limitation, they are highlighting limited generalizability of their study to the whole population. It might be generalizable, but from their study, they say it might not be generalizable to everyone, right? Another,
sorry to interrupt. I think we should wrap up now.
About 30 seconds. 30 seconds.
Okay, sure.
So again, this study is a retrospective design. So that's a study design thing. The highlighted in blue is patient procedure and numbers are low. So sample size. And they relied on telephonic survey. That's a methodology, and future of research. That is, we should be focusing on perspective. And they have highlighted during that they've slipped in a backhanded compliment that we report one of the longest follow-up cohorts in the literature, right? So they've tried to mitigate the effect of limitations in the limitations itself by giving a backhanded compliments, right? So if you start off with the why, and you have 2 or 3 identified key points, I think every key point should basically funnel towards your conclusion, and limitations should answer your anticipated criticism, and conclusion will always be to re-emphasize the why. So always start with why and end with why you are doing the paper, right? Thank you very much for patient listening.
Thank you, Dr. Arvind. It was really illustrative, and I am very happy that you illustrated with the help of the published literature, highlighting the important points to which are going in line with your topic. So what we have to see is that discussion should address what is the goal of the research, and at the same time you should not be very critical either of the authors for whom published literature is existence, though you should be sticking to fact, and also not so much critical of yourself. Limitation should be truthfully told, and obviously if there is any finding which is illustrious, which can lead to further study on that topic, should be also mentioned in the discussion. And Dr. Arvind, if there is right now no question on the chat box, so in case these later on crop up, then kindly be generous to answer to these. And I hand over back to the organizers, and thank you again for a very illustrious talk.
Thank you very much.
Thank you, sir. The session was really insightful. The next topic is on citation, its styles, and citation software such as Mendeley and Zotero. The experts are Dr. Anjan Dua as the speaker and Dr. Anup Mehta as the chairperson. I would like to request them to take over now.
Here to be part of this excellent workshop, which is going on online at CIPS. I talks by other speakers.
I can't hear you. Your voice is breaking. Is it at my end only?
No, sir, it's breaking.
Yeah.
It's because he is traveling. Go on, Anjan.
Sir. Okay. Thank you so much, IAPS team, respected President or Secretary, my colleague, Dr. Prabhu. I hope the screen is visible.
Yeah, it's visible, but it's checkered format. Okay.
Yeah. Okay. So this is the citation styles. Referencing and citation is given the least importance when you come to writing the paper, because it's considered to be very mundane, and generally after doing the hard work, if one doesn't give much importance to this spoils the paper at the end of the day. So what I'm going to present, I have nothing to disclose here. The videos and images that I'll be using are either taken from open softwares or my own from my own subscriptions for demonstration purpose. So just to understand the various how to use them, you have to first understand why citations and referencing is important. See, if we go to and find out from a dictionary, it is mentioned as citation as an act of quoting. That is, you use citations to speak or write from another, usually with the credit given and acknowledgement given to the prior worker. It is used very judiciously and artfully to acknowledge the other's work and contextualize your study, like my previous speakers have already told how you use them to build up a crescendo as to why, form a backdrop as to why you have conducted a study and what you are going to demonstrate and what are your findings in your study. So when you give a context, the result comes out well and people understand what you are trying to refer to. So a well-referenced paper supports the novelty and enriches your paper and gives value to the work that you have given. So, and also avoids the most important concept of plagiarism. So when you have taken something, if you want to quote it as such, copy paste, then you have to put it under quote unquote and then again cite it. But without citing somebody's work would amount to plagiarism. I think Dr. Subsequent speakers, Dr. Sarin would also address this part. So it's very important to cite rightfully, judiciously, and in a proper way to improve the credibility of your own scientific work. And the key word is accuracy. Of course, nowadays it is a cut-paste business, but if you do not do it properly, or if somebody else has put a citation which was wrong in the first place, it initiates the circulation of false facts. So it becomes difficult to retrieve those references by subsequent readers, and decreases your credibility, and then decreases the chances of your paper to be cited further. So it's very important that you do it very rightly, accurately, and also it is displeasing to the cited author, and it misleads the reader. So overall, if you see, there are two components. Broadly, we divide it into the in-text, the running referral to the numbers or the author and the year, depending on the style that is used. That is called the in-text citations. And the bibliographic details, or the list of references that are attached at the end of your paper, that details the references that you have chosen to cite. So different styles, if I have to enumerate them, it's more than 500 styles are available, but we will stick to Vancouver. This is a system where the references are numbered consecutively as they appear in your text, and mentioned as a number within parentheses or within square brackets, or it could be also just plain number without any brackets or superscript, or square brackets, but in superscript, or a combination of, like, for example, the one shown below, they have used a number, Arabic numeral, within brackets and in a superscript. This is the syntax I thought we must follow. That is what is followed in GIPS, and other journals have their own slight modification of the standard Vancouver system. Here you would note that in text, it comes after the period within a parenthesis. For articles, they allow 6 authors to be named. And if there are more than that, we use abbreviate that by using et al, the title of the article, the abbreviated journal, the year of publication, the issue, the volume, and the page numbers. You can even abbreviate it further by writing 130-5 rather than repeating 130 and 135 again and again. So you have to refer to the current format that the journal you are going to submit, and stick to it. And of course, there are other formats for chapters in book. It could be a newspaper clipping, it could be a magazine that you want to cite, it could be a blog, it could be an internet article. Depending on them, they have varied formats for that particular item that you want to reference. So to the uninitiated, this is the method I chose when I was 15 years ago writing my thesis, just to show how I was doing in those times. So this was the introduction I wrote. I wrote the copy pasted the references from PubMed alongside the sentences where I needed to cite, then wrote this reference at the bottom, then put the number there, copy pasted from the comment, or one could also write it there alongside the entire the citation as such, and then paste it at the bottom. Now this is very easy if it is involving only 1 or 2 pages, or for dealing with 10 to 15 at max references to manage. But you would soon realize that this is not practical. Why? Because if you have to write the entire thesis and there are hundreds of pages, at least hundreds of pages, then scrolling up and down would not be practical. And what if there are multiple citations to cite at various sections of the paper, for example, in the introduction as well as in the discussion? So those are very, the situation would, increase your headache. Definitely you will have a headache at the end of the day. And suppose you want to remove a portion of the article, you want to rephrase it. So removing that and ordering the references, it becomes a task, and becomes takes all the hard work, it spoils your day. So what do? We use these citation managements, which are very easily available now, and one should start using them, get a hang of them, using them. So by definition, they are basically softwares which handle these references. They help in organizing the references and would generate the citations and the bibliographies automatically. So you can focus on your work, your own insights of your work, what you want to write and focus and project, rather than wasting your time in arranging these references. And at the same time, using them would ensure that you are accurate and there are no errors that would ensue during these while you use the citation management. And also there are platforms which increase the collaboration abilities, and therefore at the end of the day your productivity of your team improves and efficiency improves. So two platforms I have chosen, Zotero and EndNote, to demonstrate how they're used. Mendeley purposefully I have not used because I do not use it. Zotero was the one I started using initially and then shifted to EndNote. So these are, although Zotero and Mendeley, the features are more or less the same. EndNote gives you certain added advantages, although at a cost because it needs a subscription. So coming to Zotero, this is an open source manager and uses various plugins which helps in downloading the references directly from the browser, and you can group them. You can, I'll show you directly in the demo section how to go about. And these are additional features for EndNote. Of course, it is expensive and got a slightly longer learning curve. So, so this is the video. I think it should play. So downloading and installing is not different from any other software that we use. So I'm skipping it here. So you go to the original website, download as per your machine that you are using, and once it is installed, you will have this interface. So in this interface here, you can see there is a file, edit option, view option, tools, and help. This center is where your library gets populated, and on the left you have the folders which help you organizing your articles, and you can group them accordingly. If you have multiple papers to work simultaneously, you can group them into different papers. And then, so this paper shows, this video shows how I'm importing a particular article. This article I was interested in, and I thought of having in my library, which I would use subsequently in my document. So this is how it was done. We went to, if you relook carefully, I'll just go back here. Every article in PubMed will have this function, either cite or you can go to send to. Send to option will also give you this file which gets self-downloaded, and importing, this is the n.nbib file. So importing it is basically very easy. Go to the file tab, import, and then browse it to the download folder or the folder where you had downloaded. It's just like attaching a particular attachment when you send an email. So once done, this library will populate your center field, and this is how you keep adding references that you are interested in, and it gets populated. At the end of the day, you can see that there are 3 or 4 articles I have downloaded. These are the 3 files, and I want to, group them together. As say, for example, here these are all vascular anastomosis techniques that I was interested in. I'm preparing a group here, or a folder, subfolder here, named it as such so that it is easy to find later on, and then copy paste it to that. So you have now a folder with a named vascular anastomosis with those 3 the files downloaded, and this shows on the right the metadata of the individual files. You can edit them actually. If there is grossly some error, if you can note in the file, in the original metadata of provided by PubMed, you can edit it also, although it is not advised. Generally it comes out clean, but if there is something which needs really to be edited, you can edit it. It's not that you cannot edit, and various sections in the template will allow you to edit if it is needed. So going further, how do you integrate it to your document? So once you have this Zotero downloaded, you will have this tab here. You can see Zotero on top ribbon. And once I have written my introduction part or any other section, and I feel that I need to put a reference here, I go to edit option on the left, or add, and I add citation, and we choose the Vancouver system here I have chosen, which is generally the last one if we go alphabetically, and this ribbon comes up. This is the Zotero field where if you type in the Starzl was the article I wanted to fit in. So I typed, it came up, and it is auto loaded here. Similarly, I write further about the article, whatever I needed to, and felt that further articles need to be referenced. I do it as I did earlier by clicking the edit option here, writing the first name of the author. On the drop down, you will get the preloaded, which is already populated in your library. Click and you get the in-text citation here. And after adding that, you can add or add bibliography here. If you click, the bibliography stands out at the bottom of your last page where you can use it, put a heading according to your choice. Moving further, this is the interface of EndNote. It's very similar. On the left, you have, so this shows my own library. You can see there are 2,458 articles which I have downloaded and arranged them in different subgroups, various papers which I'm working on, and the main, the center one have them arranged in alphabetical order. So if I have to do that, so importing is same as that for Zotero and Mendeley. I'm not going into the importing part of it, but there are certain additional features that we'll see that you can do here, and I thought you must see experience it here. So this is the interface that opens up when you click insert citation. Again, write the first name of the paper, author of the paper. You will get in the drop down the exact one. Here I wanted this authored by Chaudhary et al. So it came up as was happening in Zotero also. Here I have chosen the style as Vancouver. I'll show you how to choose any other, and without much of an issue, and changing the style in the entire paper, it gets changed within a moment without having to bother about dealing with each reference separately. So here I have clicked insert citation. So 2 citations I have added, and now I am adding the third and the fourth one in a similar way. So this is the one I wanted. So I'm just hastening up here because this is not providing you any other new information. It's the same process going on again and again. So now that you have seen that 1, 2, 3, and 4 articles have been added, I want to change the output. Suddenly I realized that my journal doesn't want the square, I mean the parenthesis, but it needs a square bracket. So what do? I go to the EndNote section. Under that, I have already preloaded another style which I have renamed as Vancouver JIEPS. So you can see that those 4 citations in text have changed. In EndNote, you can change the configure the bibliography also very easily. The bibliography is the list of references that gets populated at the end of your text. I can appreciate that the fonts are different. My text is written in Times New Roman and the references are in calligraphy. So I have to go to layout, and we can change the spacing, change the font size, and it's done. I can also change the heading from this to a little slightly bold appearance. I do that by going to the layout, and that takes care of the layout of the references. And as you update, you can see that it's done. So this is how we do in EndNote. The next part of the presentation, if you are really into it, you can also generate your own output style. So you can configure the output because if you have noted, I had one preset as Vancouver JIPS. So here I want to make one more output style. I go to Style Manager, take the Vancouver as the base template, go to Template, and click the in-text citation portion, select it, go to Edit, and superscript it if I need a superscript version of it. So that takes, and I rename this format as, say, something like Demo Vancouver, so that it's a distinct name. And next time when I have to come back and use this, I can do that effortlessly. So going back to that article, I am trying to find out this preset that I have added now, Demo Vancouver. Now you can see it is superscript as well as in square brackets. So there are certain more features that I thought are important, but because of time constraints, I'm not dealing with. People who have done systematic reviews would appreciate that this is a very wonderful tool to remove the duplicates. That's the first step when you synthesize data, when you deal with the multiple filtered articles that you have to deal with. The other important point was that it's not always from PubMed that you have to download. You can do it from the website of the journal website itself. Every paper will have this option, this cite option. You click cite. As you click it, another window might open, which will ask you what exactly do you want. So I want the entire thing and export, and you get that in your download folder. And this you can import to your own Zotero or EndNote library. So with that, I think you have got a gist of it. You have to choose the right, depending upon your expectations, the budget that you have, the exact function that you need to harness from these softwares, and choose with the free one. Maybe with the Zotero, once you get a hang of it, you can have your own paid version, which gives additional features. So it helps in automating, so you can focus on your insights, generating valuable research insight, rather than doing the mundane task of arranging them, deleting them, renumbering them, editing them, restyling them. These are things which can be relegated to these softwares, and no more you have to waste your time in this work, and also ensuring that you are 100% accurate. Therefore, you are effectively improving your efficiency. So this is a suggested reading material that is very important, because what I showed you are the two sources. It could be journal, it could be book. If you have to cite a monograph, if you have to cite a blog, if you have to cite article in newspaper, all those formats and sub formats are there. And this is in the PubMed NLM website. You can click this and get the exact way how to cite a particular thing that you want to cite. So to conclude, accurate citations are the backbone, and these reference management tools are therefore indispensable now. Help and save your time and reduce the errors, and the right tool that is chosen depending upon your need, but ultimately they all pave the way for a more efficient and effective writing. Thank you for your patient listening.
Thank you, Anjan, for a wonderful talk on highlighting the importance of references and practically demonstrating Zotero and other techniques and nuances of the same. Again, I'll conclude by saying that accurate references are absolutely credible, as Anjan has already said. The suggestion is that you must read the original article and reference instead of cross-citing them. Because, as Anjan has also said, there are chances that errors may be there in original citation, which you are likely to carry forward. So that again creates issues, because if somebody wants to read that article, he will not be able to read it there. Thank you very much, and I thank the organizers for having us here. Thank you.
Thank you so much.
Can I ask one question?
Sure, sir, sure.
Although I recently came to know about the answer of this question also, but I'm just asking for the people.
Testing me. What?
No, not testing you, because
for everybody's
for everybody's like this extra information about the software. When we use these softwares for management of citations, we make a group of the citations.
Yes.
Okay. And suppose I write the paper first, and I use that software, and I cite my references using this particular any one of the software. Now, suppose I want to show this to one of my friend or one of my co-author, and that co-author in his particular ID of Mendeley or Zotero or whatever, he's not having those references. So how do you deal with it so that all the authors, like you spoke something about group? So
yes, sir. So yes,
highlight?
sir. Right. A very nice point. I think I have the answer. So for example, my research fellow uses Zotero and I use EndNote. So there is not even a change of platform. I mean, not only a change of the owner of the particular paper, but a completely different platform is being used. So what do we use between us? There's a way to use a common ID actually, but then that is not something what is advisable. But using the same software actually manages, they do not hamper your changing. Suppose you want to remove a particular section from your manuscript. If you are using Zotero, even though it is not in your populated in your Zotero database or reference, what do you call it, the library, it will still have that format integrated in your manuscript. It will not change. I mean, if you have to remove a certain section, the renumbering will happen at the end of the day.
Okay, okay. And suppose that manuscript goes back to the first author, then I mean, that renumbered manuscript will be perceived
there with
by
him. Yes, sir, with him. It is just at the back end it is happening. What is happening at the back end. It is the document which you are handling. It is supported by the references which are there in the back end.
And one more, sorry, one more question. Like I am using Mendeley, I have not used other two. So why? I mean, why is the preference for EndNote or why
So,
is
so that is because I get from university subscription. That depends on the institute basically.
I just wanted
Not
to
all of them have chosen to use it. I approached my library and they, I mean, somehow that application was forwarded and I got it through. That's the only idea.
Thank you very much.
Otherwise, no specific, I mean, reason to choose something.
I must appreciate you. I mean, prepared your talk very well, and it was nicely demonstrated also. Thank you.
So.
Thank you, sir, for this detailed and insightful session. Now that we are done with the manuscript formation, it brings us to another important topic, that is responding to reviewers' comment. And the experts for this session are Dr. Prabodh Goyal as the speaker and Dr. Devendra Yadav as the chairperson. I would like to request sir to take over now.
Thank you, Shivani. And thanks to IPS for giving me this opportunity of inclusion in this much awaited academic activity. I think after finishing your preparing your manuscript, when you submitted your manuscript and you receive a lot of query, don't worry, you should be happy because at least your manuscript got a chance to get some comments from the reviewers, and outrightly your manuscript was not rejected. Actually, the reviewers comments is a balance between reviewers, editor, and the author. And how we manage this balance, Dr. Prabodh will explain exactly how to give answer to all these queries in a very polite manner. Over to Dr. Prabodh.
Thank you, Professor Yadav. Thank you, everyone. So now I shall be discussing on responding to reviewers' comments. So we are assuming the stage has reached when we submitted our manuscript to the journal and then logging in every day to check if it has been sent for peer review. Then suddenly one day you see in your inbox that a mail has come from the journal that you can log in to see the reviewers' comments. So that is very exciting. But when you go to the reviewers' comments, you sometimes feel a setback. So how to handle the reviewers' comments? So basically, this is an illustration of what peer review is all about, when the reviewers are there to find out the faults in your manuscripts. But trust me, the intention of everybody is to make the manuscript publishable, to make it better, to make it more useful, to make it suit the journal standards, and to make it useful for the journal's audience. However, when we first read the comments, we sometimes have a feeling something like this or this. Yet peer review remains the best system we currently have for quality control in scientific publishing. So peer review process is fundamental to scientific publishing, and other than the common advantages that we all know of, it provides an external perspective to your manuscript. So when I'm working on a topic, I am so much immersed into that topic that I literally get to think parallel. Some of us have the dynamics when we do parallel thinking, but otherwise the peer review serves the purpose of parallel thinking or looking at your manuscript from a different perspective. Now, responding to reviewers' comments or those parallel thought processes is a critical skill for successful publication, because if you are not able to convince your reviewers, if you're not able to provide them with appropriate answers, the next thing would be rejection. And if you can answer their questions well, then of course your manuscript is accepted. So in this presentation, we'll discuss the process of crafting effective responses to the reviewers' comments so that the chances of acceptance are maximized while maintaining scientific integrity and professional relationships. Now, see, these are the various answers you can get from the reviewers. Either they accept it without revision. Well, that is very, very rare. I think I have had 3 or 4 instances only. Minor revision, major revision, reject with permission to resubmit, or an outright rejection. So, like in my first presentation, I'm trying to compare it with the date again. So once you come back from your first date, you get feedback from her friend who says that my friend liked you but thought you talked too much about yourself and you didn't answer enough questions, didn't ask enough questions. Now, what would you do? One possible option, well, your friend is wrong. I am a great conversationalist. Alternatively, you can say, thank you for the feedback. I was probably nervous and will definitely be more mindful next time. So these are two approaches. I would not say which is right and which is wrong. It's up to you to decide. It is situational. It depends upon the type of comments that you got. But broadly speaking, there are 3 principles which are important. So timing and organization, professional attitude, and being thorough. So when I say timing and organization, you should begin working on the revisions promptly. So there are 2 aspects of it. So the reviewers have sent it back to you, but they have been through the entire manuscript. The sooner you submit it, the lesser work for them to, because otherwise if it's a long time, they might have to go through the manuscript again. So create a systematic plan for addressing their comments and follow the journal guidelines. Now, second aspect is professional attitude. So while you answer, you have to remain objective and unemotional. Don't feel hurt if something which you have written is not accepted by the reviewers. Be objective, be unemotional. It is good to view those comments as opportunities for improving your manuscript. And you have to be thorough. So address every comment in which has been provided to you. Even if you disagree with those comments, there is a way to answer it. So we'll discuss those ways. Now, this is one of my manuscripts I recently submitted to Journal of Pediatric Urology, and I got so long and elaborate comments. So I believe that the easiest way to handle is create a working document with all the reviewers' comments and number each comment for ready reference. See, something like this. So I create a Word file. I have put a serial. I say reviewer 1 and bottom reviewer 2. The comments of reviewer 1 have been numbered 1, 2, 3, 4, 5. I have left a column for author's responses. And for the ease of reviewers, I do make it a point to mention the page number and line number on which the respective change has been made. Now, sometimes what happens is you get similar comments or mutually contradictory comments on the same aspect from different referees. So you can try to group them together by identifying major themes and concerns. So like I've done here, review 1, review 2, review 3, and at the bottom, these are the comments related to methods, related to literature, related to discussion, related to figures. So while you have to answer as per the original format, but handling them as per themes helps you approach the entire thing in a systematic manner. Now, after this, you have to understand that priorities change sometimes based on importance. So, for example, if mostly you'll get reviews which require some 1 hour, 2 hour work. But sometimes when a major revision is suggested, you might have to divide the work. Say, for example, in week 1, we'll be talking or working on the aspect related to the statistical analysis. Week 2, we'll work on the figures and formatting. That's up to you. You can reorganize as per whatever you feel is comfortable for that particular manuscript. Now, while you're planning your responses, first thing is read the comments multiple times. Generally, what happens, reviewers are also busy and they would like to place their comment as a small line. Very few reviewers will actually take out time to give you the entire background of the comment and write it in detail. So the more number of times you read the comment, the more you get out of it and more you understand what exactly the reviewer might be wanting for. Then you have to assess if the changes which have been suggested are actually feasible in context of your study. That helps you decide you have to agree or disagree. You might have to do additional data analysis, create a timeline, and of course, you should consult your co-authors when you're making changes. Now, crafting the document like the format I have shown. So use a clear and organized format. Copy each reviewer's comment verbatim. Don't change the reviewer's comment. And for each comment, provide a point-by-point response. Once you made the response, also give reference to the page number where, and maybe the line number where you have changed inside the main manuscript. I also prefer to highlight those parts of the manuscripts in maybe a yellow background so that it's easier for the reviewer to follow. So this is how we work upon it. I'll give few examples. Okay, that's the next slide. Now, when you agree with the reviewer, so first thing is thank the reviewer for the suggestion, explain how you implemented the change, reference the location of the change in the manuscript, and provide additional data or analysis if required. So that was the first comment. I don't have to add much. Analysis was well conducted and authors had a significant number of patients. So my response was, I have removed the page number, line number section to accommodate it here. I, on behalf of the entire team working on this study, want to thank you for acknowledging the importance of this study and the hard work that has been invested. I'm referring to the hard work by the editorial and the reviewer team. Till date, such data is somehow not available in literature. This will be very much relevant to the pediatric urologists. Thank you again. So I have acknowledged that what they are saying. Now, the second comment was, I believe that where you have used reference 16, you should have been reference 15, which I found was right. So I said complied with and changes highlighted in yellow. So this is in the manuscript. And the third column gives the page number and the line number. This is another example. Thank you for this very helpful suggestion. We have added a detailed description of our statistical methodology in the method section, page 5 to 6. We've also included a new table, table 2, showing the complete statistical analysis. Now, there might be situations where you agree only partially. So acknowledge the reviewer's perspective, explain your partial implementation, justify why some aspects were not changed. In fact, it's a good idea if you can attach some evidence and provide alternative solutions if appropriate. So how? We look at it here. One comment was, this was a paper on stretched penile length nomogram. You have recorded age, weight, and stretched penile length. Not that it is a must, but why was height excluded? So it's a very valid question. It would have been interesting to correlate the SPL to height as you have done with weight and age. So my answer was, we appreciate the reviewer's astute observation regarding the exclusion of height measurements in our study. First of all, I have acknowledged that he has made a fine observation. The study question was focused on establishing age-related nomograms with weight as a key covariate. While the weight measurements could be obtained with high reliability using calibrated scales, the height measurements take relatively longer measurement times and can be confounded by variability due to postural factors and measurement technique variations in busy clinical setting that you see in government hospitals. So I have agreed with his observation that adding height would have added value to the study, but I have given the reason why height was not included. So another example, we appreciate this insight and have partially implemented the suggested change. While we agree that additional control experiments would be valuable, we were limited by sample availability. However, we have included new statistical analysis on page 8 and addressed this limitation in the discussion, page 15. Now, there might be situations when you completely disagree with the reviewer. You are still supposed to remain respectful and professional, provide a clear scientific justification with evidence if possible, include supporting references, and offer alternative approaches. So here's another comment in the same paper. I noticed that the sample size of boys is relatively small. Could the authors please discuss the necessary number of participants to create a more robust nomogram that can be applied globally? So I replied, we appreciate the reviewer's important point about sample size requirements for robust nomogram development. The study in its present form includes 1,276 boys. Now, we had used GAMLess. That's a generalized additive model for location, scale, and shape. So GAMLess modeling with cubic spline function has been utilized in the methodology, and the normalized quantile residues show a normal distribution. Therefore, my first point that this data is normally distributed. Second, while our current study provides valuable initial reference data, we acknowledge that a larger, more diverse sample would enhance global applicability by establishing comprehensive standards. The authors will plan subsequent initiatives accordingly. So this is where I actually disagree with him that the sample size is small. See, you would also agree that a nomogram on 1,276 boys is a big nomogram. So I told him first point that the data is normally distributed. I have given him the statistics. And that's obviously a global statement. If the sample size is increased further, things can be better. So we'll plan subsequent initiatives accordingly. So I haven't agreed, but I have agreed. Similarly, we respectfully maintain our original approach for the following reasons. We give the justification, we give the supporting evidence, we give the references. However, we have clarified our rationale in the method section. So all these colored examples I have given pertaining to a manuscript, it has been accepted in Journal of Pediatric Urology just day before yesterday. So now I know that my answers were satisfactory. So now when the reviewers have methodology concerns, so we can provide additional experimental details. Sometimes we tend to withhold some information because of word limits. We can justify choice of methods, include control experiments, and address their statistical concerns either in the manuscript or in the document response to reviewers. And we can use the references to establish protocols as our evidence. Sometimes the concerns are related to data presentation, so there's no harm in improving the figure quality, add the error bars, clarify your legends, provide raw data if need be, and include additional visualizations.
3 minutes remaining,
If
sir.
they have problem related to discussion, then you update the outdated citations and broaden the literature review. Similarly, they may have concerns with writing and organization. We handle by improving the quality, clarity, reorganizing the sessions, and enhancing readability. This is summary of just what we discussed, do's and don'ts. So essentially, receive the comments, analyze them carefully, plan the responses, and then implement. Avoid emotional responses, avoid ignoring the comments. Sometimes you get challenging situations like conflicting reviews. So you have to address the concerns separately. Sometimes unreasonable requests. I showed you how to handle them. Sometimes technical challenges. The best practice is to maintain professionalism, document your reasoning, and be transparent about your limitations. So there are a few examples. I'll just give one of them. So see, the reviewer says the sample should be stored at minus 80 degrees centigrade as this is standard protocol. Other reviewer says it should be stored at minus 196. So the possible answer is we acknowledge that both minus 80 and liquid nitrogen at minus 196 have their merits. We will implement a dual storage approach. Critical samples are stored at minus 196, backup ELICATs at minus 80. And this is supported by recent multi-center biobanking studies. Give a reference. So you have handled the mutually conflicting comments. Then, okay, this is the author should perform whole genome sequencing for all 500 samples to provide comprehensive genomic profiling. So we have said that whole exome was performed and the reviewers say whole genome should be performed, which means going back to a study again. So we have replied that the current grant specifically covers whole exome sequencing, including whole genome would include the cost by 4-fold. A scientific rationale has been given and an alternative option has been suggested and we can enhance the exome capture. This is a similar example. I'll skip this. Then always add a cover letter telling to the editor, thank you for the opportunity to revise your manuscript. These are the major changes that you have included. It is a point-by-point response, the document that we have prepared, and a request that we believe these changes have significantly strengthened our manuscript. This is a summary of what we just now discussed. So you need a systematic organization, professional communication, attention to detail, clear justification, and commitment to improvement. Thank you.
I have a question, if I'm allowed to ask.
Yes, sir, please.
Yeah. So you very nicely covered. I mean, it is very enriching presentation you have made just now, Prabodh. I congratulate you. And my
Thank you.
question to you is, sometimes there is a editorial rejection and there are comments by the editor, or there is rejection after reviewer comments. So you're not allowed to make major revisions. So how do you handle that scenario? Are those comments useful to you to further improvise the manuscript, or you just again go with the same manuscript to the another journal?
Thank you, sir. You have actually raised a very valid point. I wanted to cover this also, but somehow time was short, so I had to focus on some other part. One thing is about your question has actually two parts. So first question is about an editorial rejection. Whenever there is an editorial rejection, generally it happens when there is a misalignment between the objectives of your study and the scope of the journal. So that is the first thing, is choosing the right journal for your research. So I have seen that youngsters have a tendency to choose a journal which has a very high impact factor, because of course that makes a difference to their CVs. But that is not just the only consideration. The editor would reject a paper only when he feels that this is not suited, or if there is a gross discrepancy in quality. Now, the second thing happens at the level of reviewers, when the reviewers outrightly reject the paper. One thing is, if I am the reviewer and if I feel that this paper should be rejected, I would still be happy to give my comments so that the authors at least know where they went wrong, or why I felt like that this paper should be rejected. And when one of my papers is rejected and I get comments from the reviewers, I would be glad to incorporate those comments in my paper, so that whenever I'm submitting it to the next journal, my paper is at least one level above its current stature. So a complete rejection with a good reviewer comment is a blessing, not a disadvantage.
And one more thing in the same continuation, many people have a tendency that from a higher journal, if paper is rejected, they have a tendency to put a article in the lower journal, lower impact factor journal. So is this a good practice, or you should still aim for, still you can aim for a higher impact journal? Because at times I have seen my manuscript rejected by a mediocre journal, got accepted by international or good quality journal.
Very well said, sir. So this has happened with me also, and in my experience, most of the authors who have published a decent number of papers have had these experiences, that one journal rejected and it got accepted in a higher or a lower journal. Both things happen. So I would rather prefer avoiding the term as submitting to a higher or a lower journal. I would say that you should submit to a journal which aligns with your study in a better way. So, in fact, we have realized, the whole scientific community has realized, that impact factor is not a very just metric to judge a journal's capability. See, ours is a pediatric surgery journal. So we publish papers which are very, very specific to pediatric surgery. So our citations are less than citations for journals which cover more than one specialty. That's why the concept of Q1, Q2, Q3 has come up, which deal with specialty specific journals. So for every specialty, they have divided the journal. This Q1, Q2, Q3 is the same concept which they use in median, and they have gone specialty wise. So whenever we decide a journal, let us look at the impact factor as second factor, and the first factor should be that the journal should align with our study.
Thank you.
Thank you, Dr.
sir.
Prabodh. Just one comment, Dr. Prabodh. Suppose if your journal is not agreeing with your inclusion criteria, the most important thing, as you highlighted in all your comments, that you should be very polite and scientific in your all queries answer. This is the first, I think, most important thing you have tell in all your submissions. Thank you.
Thank you. We have to be professional in our communications.
Yeah.
Thank you very much.
Can I ask one question, if permitted?
Yes, sir.
Even when the reviewers in our comments and are contrary to publishing, not suitable for publishing, can the editor-in-chief veto and publish it?
In my opinion, yes, sir. It can happen. It should happen, and it does happen.
It should happen.
If the editor feels that, if the editor feels that the paper has merit, he always has the option of sending it for review to other reviewers also. So suppose
Yes,
my paper
yes,
was sent
and
to
those other reviewers also rejected. Then
one
very
person's
difficult
opinion.
question I have asked.
I think
No,
this
sir,
question should go to editor-in-chief.
Yeah, I am
No.
ready to answer. I am ready to answer that. So I think it rarely happens that reviewer have given a rejection and editor-in-chief will select. But yes, it's a possibility. We have not done that so far, but sometimes, if the article, if editor-in-chief feels that it is good, he can always do that. He has a veto power. But generally speaking, if all editors are, all reviewers have rejection, then very unlikely that it will pass through editor-in-chief.
Okay, thank you.
Yes, sir.
I think there's one more dimension which we can add here. Suppose the 3 reviewers have rejected and editor still feels that this paper is good, then the editor may go by the reviewers' comments. So, because when the 3 reviewers are rejecting, then of course this is something significant. And going into the details of the reasons for rejection might help the editor decide the further course of action.
Yeah, and sometimes like what you said, many times it is rather than all reviewers rejecting, it is equivocal, and then there is a confusion that 2 reviewers have said good, 2 reviewers said bad, and editor-in-chief reads the article, he doesn't come to any particular conclusion. Then I'll send it to 2, 3 more people and take a call, and I will read, and then, finally I will come to some conclusion.
Yes, sir.
Okay, we can conclude here this session. Next session is by Professor Rashik. So we should start that. Thank you.
And Amar is supposed to be the moderator. Amar.
Yeah. Okay, so we'll start. Yes.
Shivani, you want to make an announcement?
Yes, sir. Thank you, sir, for explaining this complex topic in such a clear and concise manner. Now comes another important topic, which is decision on authorship in manuscript, the criteria and considerations. The expert for this session are Dr. Rashik Shah as the speaker and Dr. Amar Shah as the chairperson. I would like to request sir to take over now.
Okay, so good afternoon, everybody, and congratulations to IAPS and JIAPS for this excellent meeting. So as researchers, we are very familiar with the excitement of publishing our work, but authorship can be a complex and a very nuanced topic. It can also be sometimes a source of confusion and conflicts amongst colleagues. So over the next 15 minutes, we'll delve into the world of authorship, exploring the topics such as authorship criteria, order of authors, and their respective responsibilities. And who best to talk about this than our own editor-in-chief of JIAPS and past president, Dr. Rashik Shah. Dr. Rashik, sir, please take over the
Thank you. So, Amar, for nice introduction. Let's go through some of the slides. So, medical researchers, these are the 4 organizations where they've written about authorship and many things about publication. So, whatever I present, it will be something from these organizations, which includes National Association of Science of Writers, International Committee of Medical Journal of Editors, American Medical Writers Association, and COP, Committee of Publication Ethics. So we will start with why authorship matters. So authorship confers credit and has important academic, social, and financial implications. Authorship also implies responsibility and accountability for published work. This is again important. You can't publish anything. You can't publish which is not correct. You should not be fudging your data, because it is ultimately whatever the people are reading, they will take some decision on what has been published. And we have had past experience that a lot of wrong thing has happened in past. So all of us has a lot of responsibility as an author as well as accountability. Because authorship does not communicate what contribution qualified an individual as an author. So some of the journal actually ask what actually has been done by individual author. Second point is who can be an author. So anybody who does a substantial contribution to the conception or design of work or acquisition, analysis or interpretation of data can be an author. He should be helping in a drafting of the work, reviewing, and whatever the content of papers are there. He should agree with the final approval of the version, means whatever is going to be published. If you think that is not correct, you can always withdraw from being an author. You don't want to be the part of something which you are not agreeing upon. Agreement of to be accountable for all aspects of the work in ensuring questions related to accuracy and integrity. In addition, being accountable for the part of the work done by others also. So whoever is your co-author, you have to agree and accountable with whatever they have done the work. So all these are important factors while being an author of any published literature. Now, there will be some people who are helping you, but they cannot meet this criteria. So they can be acknowledged at the end of the paper that these people have helped us in preparing this particular manuscript. So these are the criteria, and then there are some more important factors that you are not going to use this for disqualifying your colleagues that something is not done properly. So basically, these are the criteria which helps us in including anybody in as an author. So again, as a journal or editors, it is not a responsibility for the journal to decide about authorships. Sometimes there is disagreement, and then in such a situation, the institute is supposed to investigate where the work has been done. Now, sometimes there is a request of removal or addition of an author after manuscript submission or publication. And in such a scenario, it is important that all authors writes and signs for this particular removal or addition of an author. Now, there are studies which are done in a multi-author group. So who in such a situation, like, there are, let's say 200 authors or 200 people who are doing study, then one has to decide finally if the manuscript is going to be published, who will be the author. This should be decided before the work is started and even before the submission. Finally, it should be decided. And all members have to be responsible for whatever is published. As I told you earlier, if you do not agree with the final conclusion, you can withdraw being an author in such a study. So this is, and then, we include the names of all authors in byline. And if there is some group involved, it should be mentioned in the byline. Then types of authorship, it can be first author, middle author, last author, or corresponding author. Ghost author, what is ghost author? So it is somebody, a person is hired to write a paper and then it is published. So again, this is not encouraged, but all this goes on. What is gift authorship? Somebody who has not done actually substantial work, but the person who is writing the paper, he will include either senior or junior colleague for multiple reasons, and then it is gift authorship. Generally, senior person will then help them in mentorship, writing, suggestion, guidance, and it is not completely out of the purview in the sense they do contribute. Sometimes junior or colleague is included so that they help in another paper or they are working together. So that is known as gift authorship. And then there is something like guest authorship. So sometimes the paper is ready by some pharma company or somebody, and they want some influential person to be author so that it becomes, the creditability of the paper increases. Again, one should not be involving in such scenarios. We'll just go through first, middle, and last author, corresponding author in some of the slides. First author, the person who has made the most substantial intellectual contribution to the work. Usually in medical field, it is a postgraduate and or junior consultant. The senior consultant will be first author when there is something path-breaking innovation or contribution where he wants his name, then he will write the paper and he will be the first author. The person is intimately involved in all aspect or almost every aspect of the project. He plays pivotal role in designing and implementing the research, including formation of hypothesis, experimental design, data collection, analysis, and interpretation of finding. They also commonly take lead and manuscript preparation. So the first author has a lot of responsibility, and it is very important. It is a significant achievement of being a first author. I still remember I published my first paper after 6 years of being in pediatric surgery. I joined in 1989, and my first paper was in 1985, though it was just a case report. But it gives a lot of your confidence gets boosted. It indicates that the researcher possesses a skill and tenacity to carry out projects from inception to completion. This position can dramatically impact the researcher's career trajectory. So more publication means you have not only the knowledge of pediatric surgery or any particular field, but you have the capabilities to complete a project. So it gives you it's a different feel to the others that somebody you can be the leader. So more the paper published, it is like, if you have to go for any grant, any future academic positions, promotions, all this helps. And all those who are associated in teaching positions, for them it is very important. So it is not just the prestige or professional advancement, it carries weight of responsibility, which we have already discussed. And the author has to be available post publication to answer any queries. During the process, of course, you are going to answer after submission, but even after publication. Now, the second is a corresponding author. So any person, any author out of the list can be corresponding author. All co-authors must agree that XYZ person will be the corresponding author. As a corresponding author, he has a responsibility to the authorship list and order, means in which order you are going to submit in the byline, list of correct affiliation. He will be responsible for liaising with co-authors regarding any editorial queries, signs a publishing agreement on behalf of all listed authors. He takes care of all journals' administrative requirement, details of authorships, ethics committee approval, clinical trial registration, documentation. He will disclose the relationships and activities with any pharma company or anything. He should be available throughout the submission and peer review process to respond to the editorial queries. He should be available after publication to respond to critiques of the work. So, as I told you, all this is first, one of the thing is written in ICMJE, which we had earlier discussed. Then who can be the middle author? So middle author is listed on a scientific paper, is a paper occupy an essential, albeit sometimes ambiguous role. They are typically those who have made significant contribution, which we have already discussed. So he is an author, but he is not contributing like a first author will be doing maximum contribution. the middle authors have contributed, but not to the extent of the first author. And then there can be mix of junior and senior persons. They help in some part of the data collection analysis. So then which order one should put it? So the person out of, for an example, if there are 4 middle authors, then the person who has contributed maximum after the first author should be in the second position, and then third, fourth, fifth, depending upon their involvement in the project. And this again, we have spoken large collaborative projects. One has to decide either in the beginning how we are going to put the names. One of the way is putting them in alphabetical orders. So nobody exactly has done more work or less work, but they are put in alphabetical orders. So being a middle author in a scientific paper carries less prestige and responsibility than being first author, which is obvious. But they are important in a crucial part in scientific publication. The last author, again, it's a unique significance. It is typically occupied by senior researcher, often head of the department or principal investigator who has supervised the project. They may not be involved in day-to-day aspect of the work, but they provide overarching guidance, mentorship. Often the resources needed to fund the project are taken care by them. So the last author, sometimes it may not be the senior person, it may be in the, the least work whoever has done can be in that position. They usually play a key role in drafting and revision of manuscript. It is a symbol of leadership and scientific maturity, and they oversee the project. The last author often is a guarantor of the work. The last author is accountable for overall integrity of the study, and in cases where the errors or issues arises, they are expected to take the lead in addressing them. The convention of the last author as a senior researcher is common in many scientific disciplines, which includes even medical journals. As I told you earlier, sometimes it may not be that way. Sometimes it may be listed alphabetically. Then the importance of the last author will not be as much as what we have already told. So being a last author, like a first author, holds both honor and responsibility, reflecting leadership role that goes beyond mere intellectual contribution to include mentorship, management, and accountability. Now, there are some special situations where two authors have contributed significantly. Then there can be two joint authors, first authors. Only thing in byline, we will have to mention that these two persons are the joint first authors. Similarly, there can be two corresponding authors. And then sometime, of course, all this has to be mentioned in byline, and this should come during the submission process itself so that there is no confusion later on. There is sometimes conflict between the authors who can be first author or second author, and sometimes even the names of the middle authors can be confusing. Some person may want to be there and somebody may be deleted. So in such a situation, if the authors cannot come to a conclusion, then the institute where the work has been carried out should investigate and give the final verdict. And then sometimes the situation arises after submission of the paper, the author dies, then what is to be done? In such a scenario, the name can be still be mentioned as an author with the mention of in the byline that the XYZ person has died on this particular date, but he has contributed significantly, so he can be the author. And today is the days of artificial intelligence. So a lot of people uses this. Dr. Kirti Rathod is going to tell us more about it. So today some of the journals are asking if you have used this, please mention in your acknowledgement. In GIAPS, we have not yet started, but I think it is the right time to start, and probably we will add in submission process that if you have used the artificial intelligence, please let us know. So with this, my small talk is over on authorship. If there are any questions, I'll be happy to answer.
Thank you, sir. Thank you for the enlightened talk. I'd just like to ask one question for the benefit of people who are just starting to publish. How should they represent their name while presenting while writing a paper? Should they just write their first name as a whole, the second name, and then the surname as a whole, or just the initial in the middle name, or the initial as the first and the middle name?
So each journal has a different requirement, and we need to go by that. Like I think the references talk was given, and in that it was mentioned that the Vancouver style. In that, basically, it comes as a surname and the initials. So we will have to just follow whatever standard way the journal wants.
No, because every journal has their own different way as to how the author's name would come up in the article, you know?
Yeah. So so each journal will have a different way of getting it, and we will have to compile with that.
So any particular guideline that you'd like to offer to people who are starting to write papers as to initially they may write their names as initials, and then later on they start writing their whole names. And when after a few years it comes to collect their number of articles, it becomes difficult for them to themselves identify from as to which articles were under their name or not, you know?
Yeah, so I completely agree with you. So my lot of articles are like Rasikesh Shah, somewhere it is Rasiklal Shah, somewhere it is RS Shah. So it is going to create confusion. So today what you need to do is have a standard way of writing, whatever way you decide. And when you submit accordingly. And you need to register on ORCID. So you have that once you have ORCID registration, and wherever else, there are multiple places today where you can register your name, and you get that number. Many journals will ask you that number also. So if you are registered, then automatically everywhere it will get populated. So today, if you are starting your post graduation, make sure that you are registered at all sites with the same name. And once you have that ORCID number, even in JIAPS, when you get enrolled on Walter Kluwer's website, it will ask for that number if you have. So if you have that number, you put it that, and automatically everything else is taken care of. So it is very important that you use the same thing. So today, as I told you, multiple names, I mean, my names are there on each article. Yeah, Yogesh?
Yeah, Dr. Sareen.
Yeah, just a comment for the major collaborative studies that we do. So therein, the guy who is given the idea, who's the principal investigator of the principal site, would be the first author. And then if we do not use the alphabetical way, then we decide how much case material a particular sub-center would kind of. So accordingly, if somebody is given 24 and the one is given 20 and 18, so the names will appear accordingly. One more thing is that when you do this collaborative studies, it's very possible that all names can't come, in the initial this thing. So a lot of articles would push some of the names on the lower down. It's not really written acknowledged, but they write the last paragraph. And even those names are actually picked up by the search engine. They will still credit you those articles if you would click on them, for your own citation and all. The third thing is that collaborative articles, as they have been done in the COVID era, wherein thousands of authors have joined hands. Obviously, they'll end up with citations which runs into thousands. So it will be ethical to kind of say, this is the citations from my particulars, and these are the collaborative papers citations. So say it's separate. So it could be 16,000 for my own articles and 5,000 from the collaborative articles. Thank you. Thank you so much.
Thanks, Yogesh. So, like what Dr. Yogesh mentioned, there is a highest number of authors in one study is 5,500. So, I mean, that that will run in pages. So, but that's for large collaborative studies, sometimes one has. And the minimum obviously will be one author in any article. Yeah. Any other questions, queries?
I have one question.
Yes, sir.
Rashid, about the disease person. After submission, he has disease, that is no problem. But before submission, before even writing up, he has died. But the work should be published, what I think. It is one of my PGTs. So
yeah.
how could I?
If he has contributed adequately,
He has done the work.
So then you can mention his name as an author. Probably
He should be. I feel he should be first author. He should be first author. But now I have to write, and the co-guide should be there also. So
yeah, you need to mention that XYZ has done the substantial work, and we are publishing on his behalf. It is on XYZ date. We can do that. I think.
do we require any permission from the family? Because this work was done in my department, and
I think it will be nice gesture to inform them and do it, so that there are no problems later on.
Okay, so with that, we'll end this talk. We'll move on. If there are any questions, they can be asked on the Zoom chat platform or our Scholarium WhatsApp group. So handing it over back to Shivani for the next talk.
Thank you.
Thank you, sir. It was really insightful. The next topic is ethics in publication and plagiarism, with Dr. Yogesh Sareen as the speaker and Dr. Sujit Chaudhary as the chairperson. Sir, kindly take over.
Can you see my presentation, please?
Sir, it's not visible yet.
And you'll have to give me, maybe you haven't given me the right to kind of be the...
Sir, you are the co-host, sir. You can share the screen.
I'm trying to...
Dr. Yogesh Sareen needs introduction.
Can you see my screen
Yes,
now?
sir. We are able to see.
But you can't see my PPT, can you?
No, sir, not yet.
We see so many award citations there on your desktop, sir. Keep on getting award every day, sir.
Can you see my presentation now?
Yes, sir. Now visible.
Right. So I'm going to talk about ethics in publication and plagiarism. And sorry, my mother was kind of obstructing me. Sorry. So background, why do we need ethics? Ethics is a major concern. Ethical misconduct is increasing. Lack of awareness is there. So the newer authors may not know whether it is ethical or not ethical. And there are multiple players, multiple issues at the author level, at the reviewer level, at the editor level, and even at the reader level. So research ethics include some of the issues which already Rasikas, even authorship issues are actually ethical issues. Privacy and confidentiality of patients, informed consent, ethical approval has been taken or not. Studies are whether they are justified, planned, and designed well, and whether they are sponsored studies and there is control of data with somebody else, and whether you have registered your clinical trials with the government agencies or not. I mean, all these issues actually fall in the research. So the most important issue that is there is whether you have fabricated, falsified, or plagiarized the paper that seriously deviate from the acceptable standards from when proposing, conducting, and reporting research, U.S. Office of Research Integrity. We already mentioned that there is peer review issues, conflicts of interest, authorship and misconduct and fraud. And the most ethical issue is fabrication, falsification, and plagiarism. And there are so many other practices. So fabrication is while conducting research, while you're doing the experiment, clinical data, while writing up research, you've done the research, you have the results in hand, but you kind of falsify or modify the results because you want the results to be reported in one manner or the other. There is bias and you are not publishing negative results. You see, if you all see your CVs, probably you have not published the papers from negative results, but they are published even in more popular journals if you've done your methodology right and you written the paper right. But sure, all over the world, people have data manipulated and got caught. And falsification is alter, conceal, or withhold. I mean, you may not alter your data, but you may conceal what you don't want to publish. Or you may have even plagiarized the photographs from the net, clinical data, etc. So that's falsification. And detection of your fraud can be done prior to publication, review editorial office, and you can ask authors for publication and the motive behind. I have been reviewer for many journals for many years now, and there is a time when I read a particular paper, I suddenly remember that something similar I have reviewed earlier, and then I copy and find out that yes, so you get caught at that level, but you can get caught even after it is published. So after published a publication, and if you're caught, then there are a lot of actions that can be taken. Retraction is the usual one. If you would go to PubMed, there are so many articles that get retracted on a yearly basis. Then what can you do about it? The editor-in-chief can ban the author for publication in the journal for 3 to 5 years and inform the co-authors and editors of related journals of action. For less serious cases, you can place the author on watch list so that his or her papers, when they come, you have to really review them very closely. What more can be done? Actually, the journal or editor-in-chief can't do much. Ideally, he should inform the institutional head, I mean, the director or the dean, and then that director and the dean actually have the responsibility to kind of, hold an inquiry. Of course, it has to be strictly confidential because a name, a repute can be, destroyed. I mean, if it kind of leaks out, then those institutional people can do a minor or a major kind of penalty, which may be just a reprimand, but it could be a major penalty as well. You can lose the job, and there are a lot of examples from USA and even in India, people have lost their jobs. But if institutional does not act, you can't do much. You can complain to COPE or WAME ethical committee. But journal editors are more proactive now, they might publish in journals and pages. Now, one more thing I can mention here is that if you doubt a particular data, you can actually ask them to send the raw data for you to kind of look into. So now I mentioned about COPE. So they have their own flow charts by which you can decide whether it is plagiarized or not, or whether some other ethical issues have been violated. Then you have World Association of Medical Editors. And for last 15 years or so, we also have an Indian Association of Medical Journal and Editors, of which I'm the member for about 10 years or so. So they can also intervene and help you if it comes to, that serious misconduct has been done and some penalties have to be imposed. So I know it's a little crowded, but these are the COPE flowcharts for plagiarism. If you would go on the site of COPE, just simply type COPE, you can go there, and then a lot of flowcharts that are available by which a editor-in-chief or any editorial board member can kind of know what to do and how to do. Now, plagiarism. The very word plagiarism comes from the Latin word plagiarius, which means kidnapper. So somebody has kidnapped your ideas, your brain. So plagiarism can occur when copying, summarizing, paraphrasing, or citing common knowledge, facts, ideas, and or with the words without giving credit to the person from which you have got the information from. The action or practice of taking someone else's work, idea, and passing it off as its own. It's a literary theft. The use of others' published and unpublished ideas or words or other intellectual property without attribution or permission and presenting them as new and original rather than derived from an external source is all plagiarism. By the way, if the institutions don't take action and if the journal editors don't take action and you think that your intellectual property has been violated, you can actually go to court. There are rules for that. So, had I not mentioned these references below from where I have picked up the lines above, which are the definitions of plagiarism, then I would have been guilty of plagiarism. So, it is as important as that. Just because it kind of is there available on the Google or literature, you cannot just quote it. So, how old is plagiarism? Probably Moses also got plagiarized, his testament, those 10 whatever were made by others as well. So it's as old as that. And earlier days, plagiarism was not kind of taken very seriously. People used to copy and paste and still get A grades. But nowadays, if you plagiarize, even in school, in Western world, you probably would be penalized for the same. So it's not good to kind of just sit down on the computer and make an article in another half an hour. So that's not right. So magnitude of plagiarism, yes, as found in 660 articles published in 3 top surgery journals. This was published in 2005. They found that 11.6% had identical sections copied word to word, 7.6 almost identical, and 3% identical. So if you would see these two papers, the words, the paragraphs, everything, even the abstract has been literally copied from one to the other. Of course, the later article was later retracted. Even the pictures and the photographs and the illustrations have been copied and pasted, and they get caught. So intentional versus unintentional plagiarism. Unintentional plagiarism probably occurs with the newer players in the field, where then they don't paraphrase well, and they don't quote well, and they don't cite well. But intentional and deliberate is the one who are the major players. Someone like me with hundreds of articles and want to publish more and more, then there is a tendency to just copy paste from somewhere. You can do a patchwork plagiarism, borrow words or ideas from others, faking a citation. Actually, if I say in Hindi, getting your papers published is also a kind of a lat lag jati hai. So it's you should curb that habit that you want more and more. Don't be greedy. Work yourself, and not. So even if you change a few words here and there, it is still considered plagiarism. Please don't do it. So why do people intentionally plagiarize? Is fear of failure or taking risks, poor time management skills, views consequences of cheating as unimportant, or simply do not care about the consequences. They may be lazy. They think that if they get caught, so what? Who's going to kind of penalize them? And some of us are very, very ambitious, and there's a fierce competition anyway. And we all heard this term, publish or perish. Unintentional plagiarism may not, they probably do not know. They're new to it, so probably they can't, So to do this plagiarism overtly, as some of our colleagues have done in the past, demonstrates your brashness. To do it covertly amounts to cowardice, and to do it efficiently qualifies an expertise, since the ultimate success of a theft essentially lies in the theft passing undetected. So if you're that smart that you can copy and paste and do whatever and still get away with it and nobody kind of catches you, that's the smartest thing to do. But with all the software tools that we have, probably you will get caught. So this is another two pictures I have plagiarized from the original artist, but I've given them the credit. So, but there is a disease called writer's, but side effect is plagiarism. Types of plagiarism. This is very important. Plagiarism of words, plagiarism of structure or paraphrased plagiarism, plagiarism of ideas, mosaic or patchwork plagiarism, plagiarism of text or direct plagiarism or word-to-word plagiarism, plagiarism of authorship or complete plagiarism, plagiarism of self. We'll talk about later about duplicate publication of self-plagiarism, which people don't understand that even that is unethical. So when one writes something that includes words, opinions, statistics, fact, quotations, summaries, paraphrases, pictorial representations, table, or any other information from an author or source, it's mandatory to put down a footnote or a quotation mark and or in-text parenthetical reference to the author. If there's no author, then state the source of the information. Medical journals use Vancouver format of referencing or citing, and this has to be done. So you can't add a material in your paper without citing the author.
2 minutes remaining, sir.
Is that so? All right. So representations, someone digitalizes the falling table from a book, founded, so you can't, even in your PowerPoint presentation, cannot put the table just like that without giving, but at times one kind of, so if you have used the word because or two on a page 256, that you will not be calling it plagiarism. So plagiarism versus copyright violation. It's the nature, whether it is intellectual dishonesty or not. Copyright is a legal offense for which you can actually go to court. Who's getting offended? The author is getting offended, whereas the copyright holder is the publisher. So in copyright violation, he is the one who's going to take you to task. Who enforces it? Intellectual peers. They're the ones who enforce it. But copyright violation, court may set you right. How to avoid it? Cite the original author always and get the authorization from the copyright owner by paying for the user material when it is already published from the publisher. Threshold of violation, very stringent. And fair dealing. I mean, so many publishers would actually allow you to kind of copy paste in your thesis or paper if you write along that reproduce with the permission of so and so. So I think I will just, this may be the last slide or maybe more. Student A copies from sonnet from Shakespeare and submit it as his own work. This is plagiarism. But how it is not infringement of the copyright. Professor A has published book of 300 pages. Student B publishes another book, and of which Professor A has written copy 300. This is a wonderful book, but this does not constitute plagiarism because the student B has kind of mentioned it. So if you would copy, if you write all this figure reproduce with permission form, then it's not plagiarism and not to be punishable. So consequences I already mentioned: retract, employers can take actions, your funding may be retracted by the funding agency. So this is one example from India in 2007. One gentleman was kind of removed from his job. So University Grants Commission also mentions a whole lot of levels of plagiarism. Unfortunately, we do not have such a thing coming out from NMC as yet. Repetitive publication and self-plagiarism and duplicate publication is also wrong. Again, people do it so as to increase their CV, but it's not correct. And it's defined as with respect to the issue of how much overlap is too much, a rule of thumb that someone has applied when considering amount of overlap between two review articles. Not more than 1/3 of the material should be the same. I'll just take 30 seconds more. Duplicate publication, why does it harm? It harms because eventually let's say a case report has been published again. So two cases are reported now when somebody is doing a systematic review. So that's not really right. So if an article has been originally published in a non-English journal and the author wishes to publish a translation in English journal, then also it should be mentioned. These are the last one or two slides. Salami science is when you write, you do one research or write one thesis and make multiple kind of papers out of it. That's not right. That's unethical. Molasses salami spelled backwards. It means that suppose you have written a paper of 200 patients of PUV and the results, and then you write another paper of 225 where you have already used the material that was published before of 200 patients. So this is not right and should not be encouraged. So there are a lot of softwares to check plagiarism these days. We all know about them. And plagiarism is plagiarism, irrespective of intent, source, quantity, and copyright. It should not be done. And one should not plagiarize. Keep telling to yourself, I will not plagiarize another's work. Thank you so much. Thank you for overshooting time for about a minute or so.
Thank you, sir.
Sir, you quote, I have one very short question. You quote that you can take a picture by just citing or quoting the illustration from where it has been taken. So my question is it adequate enough? Or we have to take permission from the author?
No. I must clarify what you're asking.
Yeah.
Saying, when we present our PPTs and all that, we tend to kind of copy paste. From there, the formal kind of permission from the publisher is not required. But if it is going to be published anytime, then proper permission. At times they'll ask for no money, but at times they may even charge you some.
Permission has to come from publisher rather than author.
No, it is always because once you publish the article, the rights are with the publisher, not with the author anymore.
Yeah, right.
But if the same author also wants to publish his own paper, then also he has to take permission from the publisher.
From publisher.
Then also he has to take a permission from the publisher.
Correct. Thank you.
Thank you so much.
And one quick comment on self-citation, sir.
Yeah, self-citations are not to be encouraged. Actually, it's not a good practice, but it is acceptable. No action would be taken by Co-op, WAMI, or anybody if you're self-cited. But whenever you quote citations, I quote citations in three ways. One is my own citations, then self-citations, and I also quote my citations that have come from collaborative studies and all that. So there'll be three things. So ideally speaking, when you talk about your citations, I'm not talking about a collaborative, you should deduct your self-citations out of that and then quote that I've got 1,000 or 1,200 or 1,600.
Yeah, right. ResearchGate does that automatically, I mean. Yeah, thank you.
Thank you so much.
So Vikesh.
Yes, sir.
Interestingly, I've been hearing since morning all the lectures. The current academic credentials of an individual is so accurately assessed, and the tools to assess it is so accurate that all these questions are increasingly becoming irrelevant.
Right.
I think it has been a very enjoyable program, very relevant program, and congratulations to the organizers for doing this project. I don't see any questions in the chat box from the participants. So thank you, Yogesh, and we can move forward with the next lecture.
Thank you. Thank you so much.
Thank you, sir. Now comes the topic that is the need of the hour, which is AI and ChatGPT in manuscript writing. The experts on this session are Dr. Kirti Rathod and as a speaker and Dr. Lakshmi Sudra Ranjan as the chairperson. I would like to request them to take over now.
Thank you. I hope I'm audible to everybody. Actually,
Yes,
use of AI and ChatGPT is something that's new to me too. So I don't really want to call myself an expert, but it's, I think, as very clearly said, it's the need of the hour, and we all need to know how to use this in the most efficient manner without getting ourselves into plagiarism and everything else. So yeah, Dr. Kirti will highlight the efficient use of these tools, which we can harness to improve our publications and our writing. Dr. Kirti doesn't need any introduction. He is already quite active in all our association activities. He's an additional professor at AIIMS Jodhpur and has an impressive array of publications to his credit. Dr. Rathod, please. We can't hear you. You're muted.
Yes. Am I audible now?
Yes.
Thank you very much for your kind introduction. And good afternoon to all, and thanks for this opportunity. It's going to be a little challenging for me to talk about ChatGPT now after the talk on ethics, but let's see how we can do it ethically. So, about use of ChatGPT and other AI things, mostly on ChatGPT because other AI are still evolving. So I have a proclaimer that artificial intelligence is only intelligent when you use it intelligently. So if you feed it with silly questions or silly ideas, it will not give you right answers. So this is very important to know. So ChatGPT is an AI language model. Actually, it was made for language, but now it has evolved to do so many things. Like I'm going to show some live examples, and you'll get mesmerized seeing that how things can be done in medical. Only in medical, we're talking only about scientific writing today. There are so many other things you can do. Coming to this most important point before I start my talk. So whether it is ethical to use it, as of now, there are no clear guidelines, but journals will ask you to say whether you used it or not. Few journals might even ask you that you can put ChatGPT as a co-author. Is it legal to use it in medical publication? Yes, as of now, but there are a lot of new programs coming up in universities where they are giving courses on legal implications of artificial intelligence so that they have some system to find out further how they can make medical legal things and law against use of it. And finally, it comes to your morality, whether you're using it, like if you do everything using something by a software, then there's a lack of moral commitment and also in doing scientific work. So there are a lot of benefits: rapid generation of content, improved clarity and grammar, of course, enhanced literature review, and it does save a lot of time. You can write a paper in seconds. You have to still check it though. It can help in all the stages of paper writing. As of now, it cannot submit the paper for you. You have to still submit your paper. But in future, I'm sure in a couple of years, it will submit the paper for you as well. So many of us since morning we are discussing so many things that we have to do research for your promotions, for being important in your medical societies and all, but we don't know what research to do. So for example, this is one prompt I am going to show you. Suggest research topics for pediatric surgical innovations. I'm just copying it and putting it on this ChatGPT. Is my slide still visible? Hello?
Yeah, your
Yes,
slides
sir,
are
it is
still
visible.
visible.
Yeah, so you
Yes.
can see the
Yes.
chat GPT. Yeah, okay. So I've given a prompt, suggest research topics on pediatric
No,
surgery.
we don't see your chat
No,
GPT.
but you have to unshare and then again share the screen. Then only you can see that.
Okay, I'll do advanced sharing options. Sorry for this.
No, it's okay. So,
all right, I might have to do this few times then. Can we see this?
Yeah.
Yes.
I just gave this one line and then this is the result. So these are the topics it has suggested to do research. And it has also divided it in like it is in ERAS, it is in artificial intelligence, it's an image, it's in transplant, global pediatric surgery. So it has divided it in 10, given 3. So you have now 30 topics to do research to choose from. You can just write now, write a study. You can even talk to it, but sometimes it will not interpret your accent, so I'm not using that. Write study protocol for first topic. All right. In the same thing, I've given another command. Now it has started. Study title, background, objectives, study design, methodology, sample size. Even the sample size is calculated. Study interventions, outcome. This is the protocol ready to submit to your ethical committee. Just in few seconds. So I'll go back to my, sorry, this technical issue I forgot. But I have very few sites, so it should not be a problem. So this is what I was saying. Same thing. Sometimes you don't know what title. So you can put this prompt like propose an impactful title for a paper on role of ICG fluorescence guided in minimal invasive surgery, and it will give you multiple good titles. You can choose one of those. It can calculate sample size. I'll show a live example after some time. So what you can do is you can use a prompt like this, using the attached manuscript, calculate the sample size for use of ultrasonography in predicting appendicitis. So there is an attach option. You attach a manuscript and then it will calculate a sample size according to the given data. It can obviously summarize the key findings. It can suggest you relevant keywords for searches. So if you want to find key findings of lot of literature, it can do it for you. You can also say that do it only in 300 words or in 1000 words or 2 pages. It can do that for you. It can generate abstracts for any topic you want. And I showed you now that it has written a study protocol. It can actually, if you put multiple attachments, it can actually also do systematic driven meta-analysis for you. Not in a very foolproof way, but you will have some background to work on. Grammar I already told. Now this is very interesting. This I'll show some live examples. How we can do statistics by using it. I'll show 2 examples. Okay. Now I'm attaching a slide here, a file here, sorry. So this is my Excel, this is some small data here. And then you can just say do chi-square test. To differentiate gender. This is a study on malnutrition. So this was an Excel which was fed to the ChatGPT. And see, it has given you perfect analysis. It can also suggest you which test to use, and it can, if you say it, do it more precise, you can see. You click another option, it will again generate. I'm sorry, my internet is a little slow here. So it can give you, like a statistical software, it can give you everything. So this is very interesting that you can do your statistics using ChatGPT. Let's go back to my presentation. All right. So these are the few prompts. You have to use perfect prompts, otherwise it will not generate what you want. If you attach I'll show you again. If you attach a raw Excel file, it will tell you that it can correct it for you. So it will clean the Excel file for you. You have to just say yes. You just say yes. It will ask you, do you want me to correct my Excel file? If you say yes, and it will do it for you. So this is it. And so it can actually write a paper for you. So suppose if you want to write a case report, I'm going to show this example. So at the end, so what you can do is you write, give only the clinical data to the chat GPT. You can attach it as a file, and you can say write it for Journal of Pediatric Surgery and limit it to only 1500 words, and use the general criteria for bibliography. It will do everything. If you are even more lazy, you can say make this in a downloadable Word format. So if you are lazy, you have to be smart, and this is a very smart tool. I don't know, we'll have a lot of questions about ethics in this, morality, but it is there. Maybe if you have a Mercedes, you should drive a Mercedes. Why to use the old car? If you don't have it, don't use it. But I say you should at least try and use it. It can do systematic review of meta-analysis. You tell it to select whatever articles are published. For example, here I'm saying that do systematic review and meta-analysis for urethral stent versus no stent in hypospadias surgery. You give this and tell it to identify papers. It will identify papers, and you then download those papers and attach as a file and tell it to do it, and it will do it for you. Siksha will not send me any papers for peer review after I say that I can use ChatGPT to do peer review. So if you have a manuscript sent to you, you can attach the manuscript and tell it to do a scientific peer review. And you should have gone through the paper and say reject it, accept it, or suggest important suggestions. You can give 3 options to it, and it will generate an answer for the reviewers and for the editor. Of course, there are limitations of ChatGPT. It requires user verification for accuracy, may lack understanding of our medical terminologies, and of course, ethical consideration. Authorship integrity must be maintained, and AI should be a tool, not a replacement for expertise. I'll show a couple of more examples before I, just few examples I'll show. All right. Can we see the ChatGPT slide?
Not yet.
Now?
No, not yet.
All right.
Yes, we can see it now.
All right. So I mistakenly I clicked another thing which it was telling me, and it has made a graph also for me. This was not my intention. I just touched it. Now, so this is one example I will show you. Okay, write a case report. Write a case report for publication in JIAPS. 1500 words. Okay.
Two minutes remaining, sir.
Yeah, this is just. So this case report is ready in few seconds. And make in downloadable Word document. So it's analyzing. You see the references are also given. You can say increase references. Sorry, I took the wrong prompt. Okay, I just clicked the wrong page. Basically, you will be able to download a PPT. You will be able to download a Word file when you give this kind of prompts. And unfortunately, the internet in my office is very slow today. So yeah, this is download the case report if you can see, and you can download it. Actually, the PPT which I am talking now was made by ChatGPT. I just put few pictures in it. So thank you very much. Open to questions.
I think Dr. Kirti, this really opens, a lot of questions as to how far to take this kind of technology. And I think the next step is also trying to understand which of the papers submitted are created by ChatGPT and which of them have been created by, people. I guess you still provide the original idea for the document, is it? The idea comes from the author.
You can tell the ChatGPT to generate idea also.
Okay.
You can say I want to do research on hypospadias. It will tell you. So it's crazy actually. I don't know whether we should use it, we should not use it, but it is there. It is there. It can write textbook chapters. It can give references. It can do everything. And in few seconds, I showed you live examples. Few seconds it takes.
Yeah. Yeah. Well, it is certainly an eye opener. We have to learn more how to use this properly.
It will be very difficult to identify also if it is written by ChatGPT or by someone else. You can put your formats of writing which were written previously. If I put 10 of my papers and put in ChatGPT and tell ChatGPT to write a new paper in my style, it will do that.
Okay. I think we've got some. So I think from the chat box, I can just say whether AI should be augmenting our intelligence or replacing our intelligence is the question. And Dr. Kamal Khan says that bibliography can be a problem, that references may not really be correct. Is that something that you have seen?
Yes, that's true. We have to recheck it ourselves, but the newer version, it's not doing that. So if you have a pro version, that problem is also sorted. So there's a basic version which is free, which will ask you, let you ask 3 questions every day as a beginner. But if you use it often, it will limit to use only 1 question per day. Then there's a pro version, which has a lot of limitless things, but also after a while it will stop. If you ask 100 questions, then it will stop for a day, and next day you can use. And then there is a plus version, which is unlimited, but that is $200 a month.
There are few more research-oriented AI tools available, madam and Kirti.
Yeah.
Like Julius and all these, which are like more proficient than ChatGPT in doing, in aiding the research or assisting the research.
Yes.
I agree completely that preparing an original article through AI is not a great idea, but bits of the pieces of the research using AI will improve your efficiency and increase the turnaround time of your own publication. I mean, writing the publication.
Certainly, you can take it as a help,
Help,
but
yeah.
like write everything using it. There
That's
is
why I said that we should be, see, artificial intelligence is a misnomer, actually speaking. See, there cannot be, intelligence cannot be artificial. It is like augmenting the intelligence or like assisting your intelligence. Human intelligence has an important role to play.
yeah, that's
I just want to ask, what is the privacy of this ChatGPT? So you're putting your idea into ChatGPT to generate some write-up for it. So is that idea now available to somebody else even before you published it?
yes, obviously.
Obviously, it has gone into the deep data of the chat GPT.
So anybody is going to have access to that, isn't it?
Yeah, of course.
But yeah,
it will come in the data pool of the OpenAI.
But despite of that, if you want to do really groundbreaking research, when you do it, you start with literature review. Even if you want to invent something, you do some research through your computer on Google also. Now Google knows you are working on something. So you are not protected otherwise also.
Yeah.
And the language which is given by ChatGPT is very characteristic. So those who are using ChatGPT, they will immediately realize that this is written by ChatGPT. And nowadays AI tools are available which can detect ChatGPT language.
Yeah, so all these things are the problem is you create something with ChatGPT, then you put in Grammarly AI and tell it to change it. Then you will not detect it. You can fool around. There are so many options available that it's very difficult to detect nowadays.
Okay. Well, it was an eye opener for me because I personally have not used ChatGPT or AI till date. So I shall try and see what it throws out.
Unproductive work where you waste your time. I'm not talking about medical scientific writing. If you want to send some invitations, greeting cards, something, some banners you have to make for your something, can be used for that.
Yeah, definitely. Can certainly use it for our social media advertisements and campaigning and stuff like that.
Yeah, there is something called as generative AI, ma'am. So generative AI is a very good thing. I mean, these tools are not very expensive also, and we can use like creating infographics and all these things which we are doing manually. You just put the manuscript, it may help you to create a creative, like still creative or a video creative of that particular article. So for all those things, yes, it is very useful, but not for writing a manuscript. But assisting the part of the manuscript writing or the research, like statistics, sample size calculation, these things anyways you can do online, but here it becomes a little quicker.
Yeah. Okay, I think we are now 4 o'clock, so shall we move on to the next session? Thank you, Dr. Rathod, for a very eye-opening talk.
Thank you, sir. Very well explained. Now is the topic which plays an important role while considering journals for submission of any manuscript, the submission fee, APC, and open access fees. The experts on this session are Dr. Kuntal Bhaumik as the speaker and Dr. Ashuke Basu as the chairperson. I may request sir to take over, please.
Hello, can you hear me?
Yes, sir.
This is Dr. Basu. Welcome to the difficulties in uploading an article to a publisher. Now, we had a very nice talk about artificial intelligence helping writing an article. And what we say, this is going to come. Only thing I want to request to the authors that please mention that I've taken help of the artificial intelligence in writing a part of this article. And that should certain a lot of problems. Now, I request Professor Kuntal Bhaumik to talk on the difficulties that an author faces after he has written an article, the difficulties and how to overcome those difficulties. Over to Dr. Kuntal Bhaumik.
Good afternoon, all. I will just give an outline of submission fees and publication fees. A number of journals charge fees to authors of one kind or other.
Your slide is not moving, Kuntal.
Why?
I think you go to the slideshow setting and turn it into browse by individual, then they will start moving. First, you end this slideshow. I can guide you. End this slideshow, press escape.
End show.
End show, yeah. And there, setup slideshow, setup slideshow on the right side. Yeah, click here. And put this into browse by an individual, the second one. Yeah. And okay. And okay. Okay. Press the okay. Press it. Click it. Yeah.
I have clicked.
Yeah. Now make it slideshow again. No, not setup. Now go down there, right down from beginning. Yeah. And now move it. Yeah, now moving. Thank you.
We can we can divide the charges into two groups. One is pre-publication fees and another is post-publication fees. Pre-publication fees are less common. These are submission fees and membership fees. And post-publication fees are article processing charge and page fee and also color page. Traditional journals are based on reader pays model. The institutional libraries pay for access to the content. The open access journals based on author pays model. Author have to pay submission and or publication fees. And there are also discounts related to institutional membership program or society membership. And there are also some waivers of service. Regarding submission fees, both subscription-based and open access journals may charge a fee at the time of submission of manuscript. Like in JIAPS, our own journal, they have submission fees of ₹1,000. Many derived from the submission fees are used to support the journals and for the wider community. These fees may deter submission because of many journals, they don't charge. This is a disadvantage, but there are some advantages. Like it decreases competition for review and acceptance, thus enhances the publication speed. Quality of submission increases as it encourages authors to submit their work only if it is well written and relevant to the target journal. Greater accountability on the part of the journals, like quality of peer review is better and they inform the reasons behind the rejection of particular manuscript. They inform the authors. Overall, the effect on the journal quality and impact are positive. Regarding membership fees, some journals like PRJ charge one-time membership fee that covers the editorial process and peer review. They publish one or more publications depending on the level of membership. Each author on a manuscript, up to 12 authors, must pay the fee and must contribute to the PRJ community yearly, like participating in peer review. Advantages: relatively rapid publication and avoidance of repeatedly paying the pre and post acceptance fees. At present, they are offering per article price as well. Post-publication fees, these fees either stand alone or are charged subsequent to a submission fees, like page or color printing charges or article processing charges. Some journals charge per page and or per color figure to cover the cost of printing. Supplementary materials may also be charged per item or per page. Regarding article processing charge, these fees are charged after acceptance. These are to support the cost of publishing, including reviewing, first by internal review and then external peer review, technical, copy editing, typesetting and graphics, online hosting, indexing, archiving, and promotion. Payments are made by authors, institutions, or funding bodies. The decision to accept or reject a paper is conducted by peer review editors and is not related to the ability to pay. Editors do not have access to payment information upon submission, and payments post-acceptance are handled by a separate department. So APC should not be barrier to publication, and for authors who do not have institutional or funding body support, journals apply discounts and waivers and also provide information on the funding bodies. Some journals have 100% discounts for authors based in low-income countries. In some journals, associated editors, editorial board members, and frequent reviewers of the journal, when submit articles as authors, they get discounts. Some journals also give discount to the students. Predatory journals may take advantage of APC-based model to receive payment. They receive payment but do minimum preview, peer review, and processing. So, while submitting, the author should check that the journal is listed by the directory of open access journals. True open access journals have unrestricted access and unrestricted reuse, freely accessible to the readers and freely available for copying, distribution, and derivative work. So open access articles are immediately accessible upon publication to readers. They are free of charge with no or few restrictions regarding reuse via Creative Commons license. Authors typically retain the copyright of their work, and cost of publication is covered by the article processing charge. And there are subscription articles, the publications that require a recurring fee for access to their content. Individuals or institutions have to pay subscription charges, either monthly or annually. There are some hybrid journals, subscription-based journals that allow some articles to be published open access. And to publish by open access, authors have to pay APC for those articles. And readers have to pay a subscription to access the rest of the journal's content. There are some articles that are open access and the others are subscription based. So readers have to pay a subscription to access the rest of the journal's content. These are financed by combination of subscription and article fees and author fees. Many hybrid journals are published by large publishers like Elsevier, Taylor & Francis, Wiley, Springer. So the difference between open access and subscription, in open access readers are not charged. These are funded by payments for publishing made by authors or institutions, and authors generally retain the copyright. But in subscription articles, these require readers to pay. Those who have purchased a journal subscription and paid for an article, we have access to your paper. And copyrights for the published content are usually transferred to the journal. Our journal, JIAPS, is an open access journal, and two journals which we commonly see, Journal of Pediatric Surgery and Pediatric Surgery International, these are hybrid journals. Like, for example, Pediatric Surgery International. These are the latest articles. You can see the first one, open access, second one, open access. You can see we can easily download the PDF here. We have to note, we don't have to give charge. But this third one, this is not open access. This is the third one. We can see the abstract, but to see the full article, we have to pay. And this is the charge by article PDF, 39.95 euro. Journal of Pediatric Surgery, some of the contents are open access. These are open access. And article processing charge, World Journal of Pediatric Surgery, the article processing charge is 2,275 pounds. But there are no submission, color, or page charges here. So these JPS and PSI, both are hybrid journals. Some of the journals are open, some of the articles are open access, and some of the articles are subscription based. Thank you.
Thank you, Professor Bobing, for a very clear discussion of submission charge, article processing charge, and the rest of the charges that a journal can impose on to an author, and also the charges that a reader may need to pay to the journal when they want to read the article. The problem with JIAPS is that when we were in the COVID period and were running very short of financial supply, we imposed submission charges. And on that particular year, in 2022, the number of articles submitted in the journal dropped to 189. But the years previous to that, the number of submissions were 250 to 400. But now it has again come back to 250 articles per year. So if the journal imposes charge as submission charge or article processing charge, it will ultimately stabilize. And the time now has come, we are entering our 30th year, to consider whether we should increase the submission charge or impose an article processing charge. It is left to the editorial board and the editor-in-chief to take a call on. But I thank Professor Kuntal Bhumi for a nice presentation. Thank you. Over to Dr. Vikesh Agarwal.
Yeah, thank you very much, sir, for your enlightening comments. Thank you, Kuntal. Vinay and Shivani, what's next?
So this is the time for the panel to address the author queries.
So if audience, if anyone feel like asking any question on any particular topic, they are most welcome. They can open their mic, they can open their video, and they can ask questions to the available experts.
And while we are addressing these queries, all the participants who have registered should attempt the post test in the link provided. The link has been shared in Zoom chat, and it has also been shared in the Scholarium group. And essentially, the certificate will deliver after that, right?
Yeah. From tomorrow, it will start getting delivered.
I had one request.
Yes, sir, please.
It is 9 to 4, quite tiresome. So
11 to 4, sir.
11 to 4.
Yeah.
11 to 4. So that is also 5 hours.
Yes, sir.
And make it short. Ideally, select one topic and discuss on it thoroughly.
Okay, sir.
This first one is overview. So everybody knew what is the problem and what is the... Then something, these statistics and others needs much more discussion, I think.
Right, sir.
So next Scholarium may be on statistical methods, medical statistics, and that is part, I think. That would be helpful to all of us, those who are not so good at statistics.
Yes, sir. We will work on your comments and suggestions, sir, and next time we will try to incorporate them as much as possible. Any other comment, any feedback from any
Good evening, sir.
Yeah, good evening.
Dr. Kiran here.
Yeah, Kiran, please.
Sir, thank you for the wonderful sessions we have done, and it was quite helpful to us, and I had a hope that more of our residents would have joined. So that would have been good. But still, I would like to tell you that what the president said, just told that I think whenever we have any conference or any national level conference, I think we need to have a 2 hours session wherein I think offline, I think online it is good because we can't move. It's one way. It is very good. The only thing is how much of that messages we can take back. As sir told, it needs more of activity to be done. We should involve, like when in teams, when online, when we had COVID, how we used to do. So the speaker speaks, and then we have to have 5 students or 6 students as a group, like how we do in BCME. So then then we have to post those questions to them, ask them to finish that in teams. Like they give whatever we have done. We can ask them. So let the team come back and present it. So in that way, I think it is one of the ways where we can involve more of the, say, like we have a talk of 20 minutes, and then we go back again another 15, 20 minutes. We have a session.
Like a workshop. Like a workshop.
Like a workshop, sir. Yes.
Yeah.
If that can be done online, it's excellent.
Online, it is difficult. See, we have all variety of experts. Few are senior experts. They may not be so tech friendly.
Sir.
For younger experts. So we formulated something which is feasible for everyone.
Agreed, sir. No, I have no. I mean,
But,
this is
that is
excellent. I've just told that.
That is very much applicable in physical conference, and we will definitely try to accommodate that.
Sure, sir. Sure, sir.
Thank
Yes,
you.
sir. Yes, sir. Thank you, sir.
If there are no other comments, then I will request Prabhu to you take it forward for final conclusion.
Before Prabhu takes over, it was a nice session. At least I learned quite a bit from this session. And like what Dr. Biswas said, maybe we can explore one of the part of entire session over 2-3 hours. That will give us time to explore, understand the intricacies, because this was, I think, more of introducing the subject, and it needs further in-depth discussion on lot of aspects. Maybe practical training, like everybody is on their computer and working simultaneously, like reference arrangement and all that what Anjan was saying. I mean, unless you are doing it, it is bumper. So something like workshop on whichever aspect we decide, we can organize, we can plan it in another 2, 3, 4 months time and do it. But it was an eye opener for many of us, and it was very good. Thank you all for joining, as well as organizing Vikesh and Prabhu taking the lead. Please take over.
Thank you, sir. Thank you for your kind words. I also request the President, Dr. Sumitra Biswas, sir, to kindly address the audience.
Thank you all for joining. Thank all the speakers and all the chairpersons. I was here from 11 to 4. So skip my lunch. So let us disperse now and have a nice time.
Thank you, sir.
Thank you, sir. Thank you, sir, for your kind words. Before we disperse, I want to express a formal vote of thanks. To start with, I want to thank all the participants who spared their Sundays for this workshop, because unless the participants show enthusiasm, this workshop will not have any value. I am thankful to Shivani. We had a team of 2 people working behind. So
Shivani and
one
Vinay.
was Vinay. Yes, sorry, I was missing his name. So thank you very much, Shivani and Vinay. I understand that at your level, you people only get Sundays as holidays, and you have invested your Sunday to make this workshop a grand success. I hope that while you were conducting the sessions behind the scene, you were also learning from whatever has been discussed here, and this should be translated in your next manuscript. I am thankful to all the speakers and the chairpersons who have spared time from their busy schedules and tried their best to use their knowledge and experience for the benefit of the youngsters here. I am thankful to Dr. Vikesh Agarwal and Dr. Rasik Shah in particular for mastering this idea, and in general to the Indian Association of Pediatric Surgeons and the Office of JIAPS. Thank you very much. Thank you one and all. Dr. Vikesh, would you want to make the last comment?
No, just like I think the expectations of the audience, I don't know we were able to fulfill or not, but we gave our best. This was our first experiment or maybe first try. And as we grow up, we will mature, we will evolve, and our program will become better and better. Don't lose trust on us. We will keep striving harder and harder up to your expectations. This is what I want to say. Thank you very much.
What we can do, have 4 or 5 questions, what do you call, responses from the audience. If for an example, how long you want, which session you would like.
Yes.
Some feedback from the those who have attended, maybe
Most
in
welcome.
Google Form. Yeah.
Yeah. So please open up your mic and give your suggestions.
I think we can specifically ask Vinay as a resident, Shivani as a research person to express how they felt like if nobody is speaking. Dr. Vikesh to decide.
Yeah, of course. Why not?
So Vinay, you want to make a comment? What was
Yes,
your,
sir.
how did you feel
For
like after attending this workshop?
sir, for me as a beginner, I felt it many new things I have learned, sir. I would also request ki each sessions were very important, sir. So I would request ki next time when we are doing such sessions, like we are just giving only 15 minutes, sir. I would say ki at least 1 or 1.5 hour for each session will definitely help us, sir. Because many presenters have to run the slides due to short of time. I would request that.
Thank you, Vinay.
So in essence, you are telling that these individual topics may be discussed at length in subsequent Scholarium.
Yes, sir.
Yes, sir.
Now onward, we will do focus. This was the first course, and basically the intention was a certificate course also. So it had to be complete also. So maybe next time onward, it may not be a proper certificate course. It may be sort of workshop which we can do. So to make it complete, we had to include all the topics related to scientific paper writing, as we are issuing a certificate from our office. That was one of the reasons.
Many of I thought that Prabhu has told more than 100 participation was there.
Yes,
so
sir.
many of them should be junior, the senior residents and junior faculties. So my request is, if you feel shy to open up your mouth, please write it to the Scholarium WhatsApp group, what you want.
Or you send directly also, or you can send me directly. They are more open to me, sir.
Okay.
They will start pouring their suggestions immediately after this session, sir. Please
So
feel give your suggestions.
You have become the dada of them.
So we are very open to suggestions, so that helps us improve also. So please feel free to give your suggestions, whatever way you want.
Sir, we have received still 34 post-test responses. I request others to kindly go ahead. Meanwhile, Shivani, you want to make a comment? You want to give some suggestions?
So it was a really insightful workshop with experts from like every session has an expert, which was really helpful. For the change in the next workshop, we can have practical, like as sir suggested, we can have some activities which will help us inculcate the knowledge that we are learning from the session at the moment only. So otherwise, the workshop was perfect. Thank you for this opportunity, sir.
Thank you. We'll keep your suggestion in mind, Shivani. Anybody else from the audience? We have still 49 people on board. responses are 36 now. Sir, shall we conclude?
Rasik sir?
Yes, please, please.
Thank you, sir.
Thank you, sir. Thank you, everybody. Please keep on filling the responses. We had around 70 pre-test and post-test is only 37.
They will send it. Let them have tea, lunch. Don't be
Yes, sir.
right now.
That's true, sir. Okay, sir.
Okay. Thank you. I'm